Hi, Dr. Matthew.
Hi, Pramila. Hi. So all set?
Yeah,
I think
all
it's
set.
almost time. Yeah.
Yeah, just 1 minute to go. Then we'll start.
Hello, Dr. Khan. I'm Dr. Matthew from India.
Hello, Dr. Matthew. How are you?
All
I've
fine.
heard a lot about you.
Yeah, thank you.
Inshallah. Hello, Dr. Dina. We just met last week.
Hi.
Midsummer, how are you?
Hello, Dina. I'm good. Thank you so much.
Hi, Dr.
Nice
Dina.
to see
Hi. Nice seeing you again.
Nice to see you. I was just discussing with Dr. Bajaj that you were there in the Midsummer Conference.
Yes, it was a really good meeting. Thank you so much.
Thanks to you.
We should start now. It's time.
Yes.
Shall we start, ma'am?
Yeah, please.
Mansi, shall we start?
Yes.
It's already just .7. We can
Yes,
start.
yes.
So good evening, everyone. And we welcome you to another special episode of Thyroid Clinics, which we have been doing since April under the guidance of Professor Sarita Bajaj, ma'am, our President of Indian Thyroid Society. And today is a special day because today is World Thyroid Day, that is 25th of May. And we know that the theme for this year World Thyroid Day is it's not you, it's your thyroid. So we are going to have a CME lectures which on the talks and the panel discussions from 7 to 9:30. And they are all very interesting panel discussions which are lined up. Our rapporteur for today is Dr. Ganvi. She is Assistant Professor of Endocrinology at Ramaiah Medical College. So she'll be taking us through the proceedings of this meeting. But before that, I invite our President, Professor Sarita Bajaj, ma'am, to say a few words, and then we will start the meeting.
Thank you. Thank you, Pramila. It's lovely to be here. Very, very warm welcome to our faculty, especially Dr. Matiullah Khan from Pakistan, Dr. Dina Shrestha from Nepal. Dina is also the president of the South Asian Federation of Endocrine Societies. Dr. Matthew John with us. Dr. Matthew John is with us, and Dr. Ganvi is going to be conducting the show. Thank you, everyone. A very, very good evening to all of you. Thyroid disorders, as we know, are very common. They affect around 200 million people of all ages worldwide, with almost half of them remaining undiagnosed. And we know that there is a wide range of symptoms with significant consequences for health and well-being. Amongst thyroid disorders, hypothyroidism is the most frequent, affecting 1 in 10 adults in India with a prevalence of 7 to 11%, compared to about 4.6% in the Western population. Hypothyroidism is associated with a 20% increase in all-cause and cardiovascular mortality. Nearly 1/3 of the patients with hypothyroidism remain undiagnosed and untreated. As we know, this is a disease which at best significantly reduces the quality of life and at worst can be fatal. And thyroid disorders affect more women than men. There is a 3-fold higher prevalence in women and a 2-fold higher frequency in older adults. World Thyroid Day is an annual awareness day that was established in 2008 with the aim of creating and raising awareness of thyroid disorders, focusing on and educating about prevention and timely treatment of thyroid disease through excellence in research, clinical care, education, and public health. So actually, it is a week of celebration, which we call Thyroid Awareness Week, from the 22nd to the 28th. Pramila has already told us about the theme. It's you, it's not you, it's your thyroid. Wanting to make it clear that thyroid disorders lead to symptoms that are often misinterpreted by those affected. Before I end, I would like to tell a little bit about our society, which is the Indian Thyroid Society is an inclusive platform for healthcare professionals who are passionate about the thyroid. We have context-sensitive continuing learning program that address the need of clinicians, trainees, and experts alike on-site and online. Apart from encouraging academic events, we advocate research in thyroidology and promote education to the public regarding thyroid disorders. We have an excellent journal, Thyroid Research and Practice, and would like to encourage everyone to send their papers for publication. Because hypothyroidism is difficult to diagnose without testing, we need efficient and effective strategies to manage thyroid disorders. We would like to invite you from ITS to join, participate, network, and grow with us. We need to gather our forces aggressively to initiate the national newborn screening for congenital hypothyroidism. And we know that is one very important cause of preventable mental retardation, with nearly up to 53% of deliveries being performed at home across India. Neonatal screening faces significant hurdles due to untrained attendants, lack of access to necessary laboratories, and economic constraints. World Thyroid Day, that is May 25th, is dedicated to thyroid patients and to all who are committed to the study and treatment of thyroid diseases worldwide. Thank you. Thank you very much. Over to you, Gandhi.
Thank you, Madam, for the warm introduction. So without further delay, we shall start off the first session. That is the talk on infertility and thyroid. That will be, which will be going on between 7:05 p.m. to 7:35 p.m. To chair the session, we have Dr. S.K. Sharma, sir, from Jaipur with us. So I now request the IT team to display Dr. S.K. Sharma, sir's CV. Yes, Dr. S.K. Sharma, sir, is presently the consultant endocrinologist at Galaxy Specialty Center at Jaipur. He's held various positions. He's been the chairperson of the Diabetes Welfare Society. He's been the chairman for the Diabetes, Thyroid and Endocrine Conference, that is the DTECCON. He's been the regional faculty for the Public Health Foundation of India. He's also the member of the Association of Physicians of India, that is the APICON. He's also the member of Endocrine Society of India and has participated in ASICON. He's also the member of ADA, the ACE, RSSDI, and the ISPMR. I now request Dr. S.K. Sharma, sir, to introduce the speaker, Dr. Matiullah Khan. Thank you, sir.
Thank you. Thank you very much. Can you hear me?
Yes, sir.
Yes, we can.
Yeah.
Good evening.
Thank you. Good evening to all the dignitaries who are there. And it is my proud privilege to introduce our speaker, Dr. Matiullah Khan, who is currently affiliations are that he is a consultant diabetologist and endocrinologist, Bolan Medical Complex Hospital, Quetta City. And this is International Hospital, Quetta. Qualifications of Dr. Matiullah Khan is that he is MBBS and FCPS. He has many achievements. He was awarded as the Best Postgraduate Resident Award in 2016, 2 times Best Resident Nominee for PGY1 in 2014 and PGY4 in 2017, awarded as the Best House Officer of the Year 2012. Cleared all exams in first attempt, and he has many publications, the real-world effectiveness of dulaglutide in type 2 diabetes patients in endocrinology and clinics of Islamabad, Pakistan. So we have a very distinguished speaker with us. Over to you, Dr. Khan.
Assalamu alaikum. Can you all hear me? Can I share my screen?
Yeah, we can
Yes,
get
sir.
Yes,
Okay. Thank you so much, Dr. S.K. Sharma, for the kind introduction. I'm thankful to the ITS, the Indian Thyroid Society, especially Dr. Bajaj, for inviting me. I'm also thankful to my mentor, Dr. Abbas Raza, for letting me do this topic. Thanks for giving this opportunity to talk on thyroid and fertility, although this is a very difficult topic and very few research have been done on this, and a lot of things are still unanswered. I will try my level best to complete this in 30 minutes. So basically, normal thyroid function is important to maintain reproductive health and fertility in both men and women. Alterations in thyroid function can impact fertility potential. There are undiagnosed cases and diagnosed cases. Both of the thyroid dysfunction can be a cause of subfertility. Now, thyroid health and fertility in women. It is basically the thyroid is involved in all phases of reproduction, whether that is follicular development, ovulation, and implantation. The effects are on the hypothalamic pituitary gonadal axis, on the SHBG sex hormone binding globulin, and
Excuse me, Dr. Khan,
Sir,
we are not able to see your slides.
Yeah. Have you shared your slides? Like your slides, we can't see.
Okay, that's
I
why
think
I asked.
Yes.
Yeah,
now we
they are
can
coming.
see,
Yeah.
but you have to make them
full screen.
Yeah.
Yeah,
Yeah,
now
now
they are
we
there. Thank you.
Yeah. Thank you.
I thought he's just starting off the introduction and then he'll continue, but good.
Yeah.
Thank you.
So basically, I just talked about the normal thyroid function is important to maintain the reproductive health and fertility in both men and women. Alterations in thyroid function can impact fertility potential, and undiagnosed or diagnosed cases of thyroid can be a cause of subfertility. Now, thyroid health and fertility in women. So the thyroid is involved in all phases of reproduction, from follicular development to ovulation and implantation. It affects on the hypothalamic pituitary gonadal axis, the sex hormone binding globulin, and on the prolactin. And that prolactin we know has effect on the GnRH pulse. Now, thyroid hormone receptors are present on multiple reproductive cells, like in the oocytes, in the granulosa and cumulus cells, in the endometrial cells, and trophoblasts. So this becomes an important topic, the thyroid and fertility. Now, why do we care? We care because it is very much prevalent, and the prevalence of thyroid disorders in women of the reproductive age is high, and subfertility is also increasing. It is most likely because of the awareness, and the female partner in a subfertile couple carries high risk of concomitant thyroid disorder, and that may be either subclinical hypothyroidism, autoimmune disease, TAI, hyperthyroidism, or it may be overt hypothyroidism. So there are different research studies done. 2 to 4% hypothyroidism, 1 to 2% have hyperthyroidism, and thyroid autoimmunity is the most common, with 10% of the infertile couples having this thyroid autoimmunity. Infertility was seen in thyroid diseases. About half of the Graves patient and Hashimoto's had infertility. So this signifies the importance of thyroid in fertility. Now, we all know that in the women of reproductive age, both thyroid dysfunction, whether that is hypo or hyper, or thyroid autoimmunity, have various reproductive difficulties. It may result in miscarriage, it may result in pregnancy loss, or it may also result in preterm deliveries. So all these are associated with this. Now, this, we all know that there is some association, but establishing this causation is daunting. Thyroid hormone, we know, appears an important role in the regulation of ovarian function, and consequently, the thyroid dysfunction may lead to menstrual and ovulatory disturbances. Now, so before starting the talk, we would be knowing that what is subfertility, how to define that. So it is defined by the failure to achieve a clinical pregnancy after 12 months or more of regular unprotected intercourse. Subfertility is due to multiple reasons. Due to female, it is 35% of cases. Due to male factor, it is 30%, and combined male and female is around 20%, while 15% remain unknown. Now, for the purpose of this talk, I would be defining fertility as the ability to produce offspring. It has two important determinants: conception rate and miscarriage rate. So any problem in the conception or the increase in miscarriage, both will result in subfertility. Now, let's start with the overt hypothyroidism and female subfertility. Thyroid alters the metabolic clearance. There is decrease or increase in SHBG. In hypothyroidism, there will be decreased sex hormone binding globulin. And in hypothyroidism, we know the TRH is increased and that results in raised prolactin that basically impairs the pulsatile secretion of GnRH. And thyroid also, hypothyroidism causes ovulatory dysfunction. Menstrual irregularities are very common. More than half of the patient of hypothyroidism have menstrual irregularities, and they are usually anovulatory cycles. If treated with levothyroxine, we know that overt hypothyroidism, the hormonal changes will reverse and they will be restored, the menstrual pattern will be restored, and potentially you are improving their fertility. So it is very important to treat the overt hypothyroid patient. So American Thyroid Association guidelines 2017 says that overt hypothyroidism is associated with infertility, miscarriage, and adverse pregnancy outcomes. And levothyroxine improves the outcomes. Women with overt hypothyroidism should be treated to improve fertility and pregnancy outcomes. While this association of the thyroid dysfunction with infertility in case of subclinical hypothyroid is not that much clear, like it is with the overt hypothyroidism. Now, there is mixed evidence in the subclinical hypo and female subfertility, and that's the gray zone. That's the most difficult part. The studies which I have reviewed are mostly retrospective, and usually they just show that the TSH is higher in infertile women with ovulatory dysfunction or in unexplained infertility. Now, but we do know that the incidence of subclinical hypo in infertile is higher in some studies. So there is a fair evidence of link with adverse pregnancy outcomes. And actually this becomes more evident when the TSH is more than the upper limit of reference range, that is the 4.0. When it is 4.0 and above, this is clearly associated with the risk of subfertility or miscarriage. But when it is between 2.5 and 4, it is highly debatable evidence. Now, so the question rises, is subclinical hypothyroidism associated with infertility? Now, there is insufficient data. So the ATA has neither recommended for or against the thyroxine. Although in practice, gynecologists and endocrinologists all will be prescribing levothyroxine, but actually there is no evidence in favor or against levothyroxine in someone who is subclinically hypothyroid and thyroid antibody negative, who are attempting conception but not undergoing ART. This is again from the ATA guideline 2017. Here you can see that in high risk women, high risk are those who had miscarriage or who has this infertility, you have to check the TSH. Anyone coming with infertility, we check the TSH as soon as pregnancy is confirmed and even before pregnancy. Now, if the TSH is between 2.5 to 10, we also check the TPO antibodies. Now, we have to group it into, this is a busy slide, I'm sorry, but we have to group it like that, that if the TSH is more than 10, that we know we have to treat with levothyroxine. If the TSH is below 0.1, this is the thyrotoxicosis, again needs treatment. But when it is between 0.1 and 2.5, this is normal, no further workup. When it is 2.5 and 10, then there are two groups in that. One is the anti-TPO positive antibody and the other is anti-TPO negative antibody group. This anti-TPO antibody positive, this TAI, the thyroid autoimmune patients will basically have an additional benefit when they are treated. So if the patient has above 4, less than 10, above 4, upper limit of reference range till 10, and they are antibodies positive, so there is clear-cut recommendation to treat with levothyroxine 50 mcg. But if the patient has just autoantibody positive, but it is below the upper limit of reference range, below 4, but more than 2.5, then you may consider. This was basically at that point of time, the evidence for, there was no evidence against or for, so they just considered it. But we know that after that, I will discuss that, the tablet trial came. So there is no big benefit of treating just the thyroid autoantibody positive patients. Now let's go to the thyroid antibody negative patients. We certainly know that if it is 4 to 2.5, there is no treatment in those patients. But if the patient has 4 to 10, you may consider, depending on the other symptoms, and you may give a trial because the patient has come with high risk, with miscarriages, with infertility, so maybe treated. And in clinical practice, fairly, we all know that we do treat those patients. Now, let's discuss about some studies which are being done after the ATA guideline. That the first study is by Maraca et al., and it was published in the BMJ in 2017. This was basically to see the effect of levothyroxine on subclinical hypothyroidism. Is it improving or not? The subclinical hypothyroidism resulting in miscarriage, is that improved or not? So in this study, this was a large retrospective cohort, 5,000 patients, 16% of them were treated with levothyroxine. And you can see the benefit was the most when the TSH, the pre-treatment TSH was between 4 to 10. So this was 0.45. Around 55% reduction in miscarriage risk in those with a TSH of 4 to 10. While we see that 2.5 to 4 have basically no significant improvement in the miscarriage rate. One thing to note is that in this study, the thyroid autoimmunity was not evaluated. So this was pure trial of subclinical hypothyroidism. And we again know that if it is more than 4, then we should be treating it. Now, again, we should know that does treatment of subclinical hypothyroidism improve the risk? So there is lack of controlled studies whether the LT4 improves spontaneous conception. Thyroid autoimmunity likely factor to consider. Some of these women may progress to overt, so therefore, if it is more than 4, we do consider to treat it. Now we have to talk about the artificial reproductive technique, ART. So is subclinical hypo associated with poor outcomes, or does levothyroxine improve outcome? The first question is there association with the poor ART outcomes? Yes, certainly there is. But this is a big question, that whether the levothyroxine will improve outcomes or not. What we do practice, that is different. But what the guidelines say, what the articles, what the evidence say, that's different. So most studies suggest that IVF outcomes were suboptimal when the TSH is more than 4. But we should be knowing that the treatment, whenever it is more than 4, certainly treatment is recommended for all of them, because it improves all those patients who are undergoing IVF and TSH is more than 4. There is no question in it. There will be increase in good quality embryos, increase in the implantation rate, increase in live births, reduction in miscarriage rates. There is no question in it. But the problem comes when it is between 2.5 to 4. There is no evidence to suggest that in those patients who are undergoing IVF should be treated left, right, if the patient has TSH of 2.5 to 4. What we do in the clinical practice, that we will discuss in the panel discussion, but the guidelines still say that if it is more than 4, we have to treat that. Now the next thing is thyroid autoimmunity and fertility. We certainly know that thyroid autoimmunity adversely affects conception, especially when associated with thyroid dysfunction. So if the patient has just autoantibody positive, but TSH is normal, even then it will affect the fertility, the miscarriage rates will be high and all that. But if the thyroid autoantibody also is associated with subclinical hypothyroidism, and especially when it is more than 4, it has a double effect on that. It will be double trouble, and that has to be treated, that we know. There is higher prevalence of autoimmune thyroid disease in subfertile women. So we know this thing, that not only in the subfertile, but also it is causing ovulatory dysfunction and premature ovarian failure, endometriosis. In all these cases, we know that thyroid autoimmunity has a role. Now that role is a bit speculative, how it works and how it does not work. It is not very much clear, but there are a lot of theories about that, hypotheses about that. And we also know that lower fertilization and pregnancy rates are there in thyroid autoimmunity, and there is high risk of miscarriage, and also in those undergoing IVF. Now, there are multiple mechanisms. We do know that there are 2 ways. Either it is impaired cellular and hormonal response. We do know that autoimmune will result in a generalized autoimmune state. The thyroid autoimmunity will be in a generalized autoimmune state, involving the placenta, the endometrium, and all that. And the other way is that a direct effect on the thyroid antibodies, a direct effect on the thyroid, the HCG receptors. So here you can see the more the TPO antibodies, the more will be impairment of infertility. And there are 2 ways. Impaired HCG mediated thyroid stimulation is blunted, that results in impaired fertility, and also directly targeting the TPO. So Now, this is a study by Venables et al. In the Reproductive Biology. It was published in 2020, meta-analysis of 14 studies. And again, they wanted to see whether there is a difference between thyroid or autoantibodies positive and thyroid autoantibodies negative. And unfortunately, the study concluded that there was no difference in clinical pregnancy, miscarriage, or live birth rates. And basically, the authors have said that thyroid autoimmunity has no effect on pregnancy outcomes in euthyroid patients. So the TSH was 2.5 to 4, not above that. It's a busy slide, but all these 14 studies were studied, and we can see that the overall result is neutral. Then we had this study, the Chinese study by Wang et al., which was published in JAMA in 2017, the pregnancy outcome study in euthyroid women with thyroid autoimmunity. Now, I'm going into the details of thyroid autoimmunity studies because a lot of studies are present, but I've just picked the important ones. And to prove that just blindly, we cannot treat any thyroid autoimmune patient just because we want. So there is no evidence about that. Now, this was a very good study, and about 600 patients were screened in this open label study. And this is the postal study, and they were undergoing first or second IVF. So again, IVF is also being done, and the patient also has a thyroid autoantibody. So we always, in clinical practice, at least I prescribe thyroxine, but this study says something else. The eligibility was 23 to 40 years, BMI was less than 35. There were some exclusion criteria in them. That is, the history of thyroid disease were excluded, women with more than 2 miscarriages were excluded, and some other were also excluded. The primary outcome was basically miscarriage, and secondary was to see the live births and intrauterine pregnancies. So here you can see it is a big study. 32,000 were screened for eligibility, and only 1,000 of them were basically thyroid antibody positive who were euthyroid. But unfortunately, about 400 patients were excluded. And here you can see an important thing, that 27% of the exclusions were recurrent miscarriage. This should not have been excluded, in my opinion, because that's the most important subset of patients who will benefit from the thyroxine. So they excluded this. This is a limitation of this study. They excluded 27% of the patients who had recurrent miscarriages. So these 600 patients were then randomized into levothyroxine plus IVF or IVF alone. And here you can see the study intervention group and the control group. They were like same, age were same, BMI were same, primary infertility was the reason in 56% of the patient, and here in 53%. So basically similar study, just you can see that the intervention group had a baseline TSH slightly higher than the control group, and the anti-TPO antibodies also slightly higher than in the control group. Unfortunately, there was no big difference in the primary or secondary outcomes. The primary outcome were miscarriages, and secondary were clinical intrauterine pregnancies or live births. So here you can, we have proved that according to the postal study, if someone who is euthyroid, has antibody positive, has a history of miscarriage or infertility, will thyroxine help when the patient is undergoing IVF? No, this has not proven. So there were some limitations, especially the most important limitation was that the women at high risk of miscarriage were excluded. Then we have this famous UK study, the tablet study, thyroid antibodies and levothyroxine trial. The tablet trial was done in the UK in about 49 hospitals. 952 TPO antibody euthyroid with history of miscarriage or infertility were enrolled, and 2 groups were made. One was given 50 mcg of levothyroxine, the other was given placebo, to see if 2 important aspects, miscarriage and infertility. So live birth at 34 weeks was one aspect, and miscarriage was the other. And here we can see the relative risk. So the 0.97 and the confidence interval you can see crosses the 1. So it is again a neutral study. There is no difference in it. Here you can see the tablet trial, 19,000 patients were enrolled in it, and they were randomized. 900 patients fulfilled the eligibility criteria. Half patient, 450, 470 in one group, 470 in the other group. So there is no clinical significance in the live birth at 34 weeks, and number 2 in the miscarriage rates. So again, this is published in 2019. This was after the ATA 2017 guideline. So this is actually against that statement, which was saying that we do consider when the patient is euthyroid with the TPO antibody positive. So we were considering thyroxine in that, but unfortunately after this study, I think we should not. No, now this is another meta-analysis of 4 studies. But you can see the Wang et al., the postal study, which was the randomized controlled trial, is a bigger study, which was done in 2017. Then all these 3 studies by Negro and Abdurrahman and Kim. So overall, this Wang et al. Resulted in overall result. The live birth were basically the IVF outcomes after levothyroxine. The effect on the live birth was neutral. So there is no big benefit of giving levothyroxine. But when we see the miscarriage, here you can see in the miscarriage rates, there is an improvement with levothyroxine. So just to summarize all these things, so thyroid autoimmunity is the most common autoimmune thyroid disease in women of reproductive age. It is about 10% prevalent, and it is characterized by TPO antibodies positivity and usually have higher TSHs. And the meta-analysis has basically showed that there is an association. Yes, there is association, but the mechanism is speculative. And I told you there can be some local autoimmune effect and can also be the thyroid. So when you are giving thyroxine, you can only improve the hypothyroidism, not the local problem that is caused by the autoimmunity. Now, again, we have to go into this thing quickly, that thyroid autoimmunity, the thyroid hormone dependent effect may occur as the risk of subclinical hypo in women with TII is increased. However, there seems to be no benefit of levothyroxine before conception on pregnancy outcomes in euthyroid women with TII. So this TII reflects a general immune imbalance, which is failure of implantation. Furthermore, there is also subfertility, PCOS, and also associated. These are also associated with TII. Now, what does the American Thyroid Association recommend regarding the autoimmunity and infertility? The first thing is, anyone coming to us who seek care for infertility, we have to do the TSH. If the TSH is more than 2.5, we have to go for the anti-TPO antibodies. These are the 2 important points. And levothyroxine is recommended obviously for the overt hypothyroidism, but for the subclinical, there is insufficient evidence, especially in the hypothyroid, in those subclinical hypo who are TPO negative antibodies, they are going for the natural conception. There is very little evidence to support that. But we know that it has minimal risk, therefore we can consider giving a low dose. Similarly, in the TPO antibody positive patients who are attempting natural conception, not undergoing ART, again, there is no recommendation about that. Now, I will just quickly go through the last slides, if you allow me. Subclinically hypothyroid women undergo IVF or ICSI should be treated with levothyroxine. That we know that anyone who is undergoing ART and is subclinically hypothyroid should be treated with levothyroxine, and the goal of TSH should be 2.5. But if the patient is having just TPO antibody positive, then again, the patient is going to ART. There is insufficient evidence to tell that whether that patient should be undergoing or not. But giving just 25 to 50 mcg of levothyroxine has no harm. One important point which medical practitioners in our country and gynecologists practices, they give steroid to anti-TPO antibody positivity. The ATA is simply against this practice, and autoantibody positive patients should not be given steroids. We can just see the TSH. If there is increase in that, especially if it is more than 4, we should treat that. Otherwise, if it is less than 4, we should not. The similar guidelines published in 2021 by the ETA, European Thyroid Association, are also similar to them. We know that if it is more than 4 or the upper limit of reference range, we should treat. We should treat all the overt hypothyroid patients, and any patient coming to us should undergo TSH and TPO. So this is a kind of repetition. This is just endorsement by the European Thyroid as well. I will just quickly go through the some studies which were done, basically showing thyroid autoimmunity effect on the IUI. There was no effect in this study. Here you can see this Italian study shows basically that when the thyroid antibody is positive, the grade 1 embryo were lesser as compared to the thyroid autoantibody negative patients. Now, this was all about the hypothyroid and subclinical and autoimmune. I will just talk about the hyperthyroidism. The data is limited when we compare it with the hypothyroid data. So the degree at which hyperthyroidism is linked to fertility is not well known. We know there is increase in sex hormone binding globulin, increase in estrogen. In the Graves' disease, we know LH secretion is increased, and there are a lot of menstrual irregularities, hypomenorrhea, amenorrhea, oligomenorrhea, and hyperthyroidism is generally associated with early pregnancy loss with
I think we have lost him.
I think we have lost him.
Yeah,
I think the connection, something wrong with
yeah,
the connection.
internet connection failure.
I think time is up already.
Yeah, time is absolutely, the delinking is
35
occurring at
exactly.
yeah.
1 more minute remaining.
Yeah.
I think we can,
If
Gani,
you
can
can
you
join us
message
again.
him in the
Yes,
chat box?
Yes, ma'am.
I think we can take the Q&A now. Maybe he comes back, then it's different. Is there any questions?
There is no question in the Q&A box.
We don't have any questions as of
Yeah.
now.
Yeah.
Yes.
So I think we can move on to the panel.
Yes, ma'am.
What do you, Dr. Sharma, please? What do you suggest?
Absolutely, yeah. We should let's.
Hello?
He is there. So, Dr.
I'm
Khan,
so
please
sorry.
finish it in
Had this.
1 or 2
Please,
minutes.
we need to
Thank you.
move on.
Yeah.
We need to move on, please.
In a nutshell, women with subfertility or recurrent miscarriages should be screened for thyroid dysfunction and thyroid autoimmunity. Overt thyrotoxicosis, overt hypothyroidism, subclinical, is linked with subfertility, and the treatment improves outcome. So the relationship between thyroid autoimmunity and subfertility is likely, but clear evidence of benefit is lacking, basically. So these were all the things that I had to discuss, the American Thyroid and European Thyroid Association. So thank you so much for giving me this opportunity. Sorry for the interruption in between.
Thank you, Dr. Khan. Thank you very much. It was a beautiful, and you have clearly explained the relationship of thyroid with fertility. And thank you very much. I think it's going over to Dr. Kalra. We can start with the panel discussion.
Yeah, Dr. Ganvi, you can go ahead with the next proceeding.
Thank you, Dr. Matiullah Khan, for your explicit talk, and thank you, Dr. S.K. Sharma, for chairing the session. We will now proceed with our second session, that is the panel discussion on approach to subcentimetric thyroid nodules, the duration of which is about 35 minutes. So the session will be moderated by Dr. Sahana Shetty. So I request the IT team, yes. Okay, ma'am. Yeah. So ma'am is presently the professor and head Department of Endocrinology at Kasturba Medical College, Mahe, Manipal. Her areas of interest include osteoporosis, obesity, diabetes, thyroid, and pituitary disorders. She has more than 50 publications in national and international journals, and she's been also a reviewer for national and international journals. Her achievements include many. She's been awarded silver medal for research in vertebral fracture assessment by DEXA, along with BMD. She's been awarded gold medal for research on bone turnover markers at the ISBMR Mumbai. She's been also awarded silver medal for research on Hologic versus ICMR database in diagnosis of osteoporosis among South Indian subjects with low impact hip fractures at ISBMR Srinagar. She's been awarded by the Endocrine Society of India the A.V. Gandhi Award in 2016 for the best clinical thesis in endocrinology. She's been also awarded gold, bronze, and silver medal for research presentations at CMC Annual Research Day in 2013, 14, and 16, respectively. So I now request Dr. Sahana Shetty to introduce the panelists. Over to you.
Thank you, Dr. Gandhi, for that kind introduction. Good evening, everyone. So here we are for the panel discussion of today's evening, which is approach to subcentimetric thyroid nodule. With the increased use of imaging techniques, whether it's an ultrasound, CT, or PET-CT, a lot of incidental thyroid nodules are being detected and are referred to us for evaluations. Some of these turned out to be subcentric thyroid nodules. So although there are clear guidelines on how you approach and manage thyroid nodules, there's a lot of controversy on how one would approach subcentimetric thyroid nodules. So to improve our understanding in this area of subcentimetric thyroid nodules and to give us more clear directions, we have amongst us an expert panelist, which includes Dr. Rakesh Sahe, who is the president of Endocrine Society of India. He's a professor and head Department of Endocrinology, Osmania Medical College and Hospital, Hyderabad. He's also the vice president of South Asian Federation of Endocrine Societies. He's a section editor of Tropical Endocrinology, Endotext. He's also the editorial board member of IJM. So has several publications to his credit and has also chaptered several books. Our next panel is Dr. John Matthew, who again is an endocrinologist at Providence Endocrine and Diabetes Specialty Center, Trivandrum. He's published extensively and also been an investigator in several clinical trials. He was the organizing secretary of ESICON 2017. We know he's a great speaker. And a third panelist is Dr. Deena Shrestha, who is the president of South Asian Federation of Endocrine Society. She's also the president of Diabetes and Endocrine Association of Nepal, and she's an consultant endocrinologist practicing at Nordic International Hospital, Kathmandu. So we have this great panelist with several years of experience in endocrinology and management of thyroid disorders. So we're looking forward for discussion on this topic. So let me first start with Dr. Rakesh Sahe, sir. Now, the first thing we would like to know is that how does subcentimetric thyroid nodules behave differently in terms of the natural history or the risk of malignancy, or if they have microcarcinosis, how would they differ when we compare to a larger thyroid nodule?
So thank you, Dr. Sahana, for the interesting bringing up this interesting discussion. And also at the outset, I would like to thank Dr. Sarita Bajaj, the president of ITS, and also Dr. Pramila Kalra for inviting me to be here in this interesting panel discussion. So to start off, to come to the question which Dr. Sahana has put up, as she has highlighted very rightly, that thyroid nodules are very common. They are seen in, you could say, about 5% of females, and if you look at ultrasound detection of nodules, it is even more common, and you are seeing that it may go up to about 20%. You may find these nodules, and most of these nodules are sub-centimeter nodules, because they are the ones which are incidentally detected, which are not palpable, probably picked up on ultrasonography or on any other imaging modality that is done. She also spoke about CT and PET CT being done incidentally for other problems, and they picking up these sub-centimeter nodules. So classically, if you look at all the guidelines which have been speaking about the nodules, how to evaluate nodules, what we have been seeing is that we have been seeing that the sub-centimeter nodules are the ones which have a more indolent course. So they are the ones which are not sort of routinely recommended to be biopsied, or FNA is not recommended routinely for these nodules, and these nodules are the ones which are more indolent. But having said that, there are certain of these sub-centimeter nodules which are not going to behave the way we expect them to behave. They are the ones which are likely to be having a more aggressive course, and these are the ones which need to be picked up from amongst the large number of sub-centimeter nodules that we identify. So to do that, I think the whole purpose of this panel discussion is to identify those points, and ultimately at the end of the discussion we'll be coming up with these points. So what I would like to say is that I think the ones which have a suspicious appearance on ultrasonography, some of the ultrasonography features which are suggestive of a suspicious nodule, those are the ones which need to be evaluated. And also what I would say is that apart from that, we need to look at lymph node involvement, extrathyroidal extension, involvement of the recurrent laryngeal nerve. So these are some of the features that may be the features that would suggest that these nodules are the ones which require to be evaluated. But by and large, I would like to say that overall the picture is that sub-centimeter nodules are the ones which are not so aggressive, and they are the ones which are indolent and which generally do not require a more sort of evaluation is not required to a great larger extent in these nodules as compared to the larger ones.
Yes, sir. So, Sir spoke about how these nodules could be indolent and not be as aggressive as compared to most of the larger thyroid nodules. So, I would like to know from Dr. Deena Shrestha on, in general, for the benefit of the audience, how do you approach the diagnostic approach to thyroid nodules in general, and then is it different from is it different for patients with subcentimetric thyroid nodules?
Thank you so much, Dr. Sahana, and really thank you again, Dr. Sarita, and it's a pleasure to be here in this forum. So I thought, can I share my slide? Is it okay? Because it is a bit simpler. If you see, because if we see that the initial evaluation of a patient with a thyroid nodule, it's like,
Like to
you know,
full screen?
Full screen?
yeah. Yeah.
Yeah, slideshow.
So, yeah. So I think that is quite easy, right? Because it's put systematically. So we see that in general, if we see that we have like we call it an incidentoloma, like in the adrenals, same thing. If in the thyroid we found it, we can check how the thyroid is, like the TSH levels. If it is elevated or normal, then we are like, okay, and do we want to do an FNAC on it? Does it really fit the criteria? If the TSH levels are subnormal, like if it's suppressed, we can do a radionuclide thyroid scan, available in most of the cities, or at least in most of the major cities, and we can refer the patient there. Then we can see whether the nodule is functional or non-functional, right? And if it is non-functional, again, do we want to really FNA it? Does it look bad? Or then whether we just want to monitor it? And if the nodule is functioning, then I think it's easier. Most of the times we just observe it in most cases. And if it is overt hypothyroidism like Graves, then we just treat it. But I think what Dr. Rakesh Sahai said is that when we use the PIRADS, right? So why is it different with sub-centimeter? So as with most of the, I think radiologists and all the people who are doing ultrasound, we all are using the PIRADS scoring. And according to the composition, echogenicity, the shape, the margin, we're giving it scores. And really, only if we are FNing, if you see according to all the guidelines, if it is more than 2.5, more than 1, or even the most suspicious, we are only doing it above 1. But if it is reaching 7 points, right? So if it's like taller, if it's hypoechoic, if it has microcalcification, these are the ones in which they get like a bit extra points. Then if it is going more than 7 points, still we are asking them to actually follow up these rather than FNing. And I would like this panel discussion because I'm also interested, because in our hospital, actually, if we send a patient with subcentric nodule to get FNA, actually the radiologist sends us back. Says it's not 1 centimeter, follow up and, don't send it for FNA. So that's what happens in my hospital. So it'll be very interesting to know, like, do you actually FNA a subcentric nodule? Because according to the guidelines, you don't need to. So I'm just going to stop sharing. Sorry.
Thank you, Dr. Deena, for that answer. I think you asked or led to my next question. So we heard from Dr. Rakesh that how a thyroid nodule, most of the subcentimetric are indolent, but then we do have studies and literature be aggressive, and with the lymph node mets, many of these are usually PTCs could present with a lymph node enlargement or with metastasis very rarely. So here comes the question: so how do you decide which are the patients who would need further evaluation with the FNAC? And also I have a second question, that many times when we have a multinodular goiter and we do an ultrasound, that an radiologist gives reporting who gives thyroids for most of the nodules. And sometimes we see that the larger nodules have a lower thyroid score, whereas some of the smaller nodules and sometimes smaller nodules are given a higher score. So how do you decide which to biopsy then? Would you go for the scoring or you would look at the size? Is the question.
Yeah, thank you, Sahana. Yes, I think this is one of the difficulties that we usually face, but the traditional thing has been we always used to look at the largest nodule and take it up. But now with the ultrasounds which have improved and now you have the scoring system, we consider the risk of malignancy in each individual nodule to be equal to that of a solitary nodule based on the radiologic characteristics. So if your scoring is high, you tend to biopsy those nodules ahead of nodules irrespective of the size. So look at multiple nodules. If they are belonging to a higher thyroid score, you go in and biopsy them. And if you see that you have nodules which are all of a similar nature, in multiple nodules which are all similar nature and does not fit into your higher thyroid score, then you would possibly consider biopsying a nodule which has got the largest size. That is when the characteristics are very similar across the multiple nodules that you see. And I think all this has been already been told by Dr. Dina, but just to reiterate that ADA, and I think Dr. Jakesh also covered that generally you biopsy nodules which are more than 1 centimeter when they have got high risk features. And if they got intermediate or low risk features, you give a cutoff of 1.5. But saying that, we also realize our patients are really concerned about the reports that they see and read. So we do have a tendency that even if the nodule is less than 1 centimeter, like which belong to the sub-centimeter categories, if they have a thyroid score of 4 or 5, I would prefer to biopsy them and reach a diagnosis. It's not good to say that this is possibly a malignancy, but we won't biopsy it. So in our scenario, we do biopsy 4 and 5. That's it. Thank you.
Thank you, Dr. Matthew John. So I think with this, what he pointed out that if we have any aggressive feature on ultrasound, or if we have a higher thyroid score of 4 or 5, even if it's a subcentimeter, it's safer to FNA those patients because there could still be incidences where we have a subcentimeter thyroid nodules which could be aggressive. So with this comes the difficult question, like, although we want to FNA and want to know what is the histological diagnosis, many times when we subject it to FNA, the report comes back as sample inadequate for opinion. And of course, then we go for a second biopsy, and then the second FNA also would probably, if it comes as an inadequate for opinion, how do you approach this patient?
Yeah, so I think, is it directed to me? Yeah.
Yes, sir.
Yeah. So I think, as you said, that's the difficult part, because you have decided initially, based on the ultrasound features, you see that probably the thyroid score is 4 or 5. There are, microcalcifications, and probably the nodule is little taller. I mean, you're worried about the score that you're seeing on the ultrasound, and you decide to do a FNA, and the FNAC comes undiagnostic or non-diagnostic or insufficient. So in those situations, what we see is that if you look at the risk of malignancy in those, it's about 20% as compared to the ones which you are reported as considered to, where you have a much lower risk of, say, less than 5%. And so here is the scenario where what do you do? So again, I think the most important thing that we need to go back is look at the other factors, like, are there any high risk features in this individual? Does this individual have a family history of thyroid cancers in first degree relative? Does he have any previous history of neck irradiation, or things like that can actually put them in a higher risk? And suppose there's some evidence of lymph node involvement, or if there is recurrent laryngeal involvement. Such things would certainly put us at much greater risk, and would certainly suggest that we need to go about with the excision of the nodule rather than further looking at doing repeat FNAs. So I think those are situations where you would definitely go with excision of the nodule, and uh, not wait for any further FNAs, and have a clarification by doing excision.
So I think we're not able to hear you.
You're not able to hear me?
Yes. Yeah, now we can hear you.
Now you. Okay.
Yes, yes. I think the last part, just the last line.
So the last, yeah. So I think what I was trying to highlight is that we need to look at the entire features. I mean, apart from the ultrasound features, you're looking at any other high risk situations that are suggesting that we need to go for a excision of this nodule. So those are the things that we'll keep in mind, and probably err on the side of excising the nodule rather than keeping it uncertain, and keeping. I mean, the patient is also going to be very anxious, and to know what is there in the FNA, because twice the FNA has been undiagnostic. So I think this is the scenario where you would look at all the other high-risk features and go ahead with that.
Thank you, sir. So, Rakesh Sahi sir rightly pointed out that sometimes when we are faced with difficulties where we don't get adequate tissue diagnosis, we look at the risk factors and then explain to the patients and take a call. And my next question is Dr. Reena Shrestha on where any genetic testing would help us in kind of risk stratifying these patients on further management, where we have a subcentimetric nodule with suspicious features on ultrasound, but our FNAC is either non-diagnostic or inadequate sample. So there is some data with larger thyroid nodules where genetic testing did show some benefit, but so would it be helpful in subcentimetric thyroid nodules?
Yeah, I think like definitely, because like you said, the ones in which when we do the FNA, and then we do have with that we're using the Bethesda system, right? And in which it's undetermined. So there is a role, and so again, I will put out these two slides if that's all right with the panel. So mostly in my country, we do less of it. And even if we have to do it, we usually have to send it to India. So it's not very common and it's quite expensive. But theoretically speaking, we have two common molecular testing strategies. That is usually for those with the undetermined ones, the mutational analysis. And please, Dr. Rakesh and Dr. John, please feel free to bring in your comments, because this is more for me like a theory kind of thing. So, and then there's the gene expression analysis, right? So when we do the FNA, so they say that with the remaining sample, actually, you can go for the genetic information, and that is always easy. So if the 7 gene mutation, the one with BRAF, NRS, HRS, those ones are usually there, but this is a rule in. So for the first one, the mutational analysis, actually, if you have any of these 7 positive, so you rule in, so the specificity is quite high. So if it comes positive, that means these are, there's more reason, like Dr. Matthew said, that the small ones sometimes can be aggressive, and this would be a proof of that pudding, and that you might want to do surgery on it or remove it. And the second type is the molecular testing one, in which actually this is a rule out. So if you don't have it, then you actually confirm that this is not a bad one. So we can open the floor to discussion, isn't it?
Yes,
yes.
This
is how it goes.
Yeah.
So one is a rule in, and one would be a rule out.
Yeah. Thank you, Dr. Deena, for that clarification. So there is some role of molecular testing, but again, it does not give us the complete answer always, and of course, it is not available at many places. Now come to our next question to Dr. Matthew John. Now, even with thyroid microcarcinomas, again, when it's a subcentimetric, whether it is aggressive is again a controversy. So I would like to know from Dr. Matthew John, so what are the risk stratifications when there is a thyroid microcarcinomas, or what are the risk factors which would determine the risk of a lymph node metastasis or distant metastasis for patients with thyroid microcarcinoma?
So the fact is that although we consider thyroid microcarcinomas are as indolent, when you look at a large series of patients being studied, and with a large percentage of these patients undergoing a surgery with lymph node dissection, basically the central lymph node dissection, irrespective of the size of the tumor, what has been found is that in series up to 40%, but at least on an average, 20% of patients do have lymph node metastasis, even though the carcinomas are micro in size. And around 3% of these malignancies do also have metastatic lesions also found. So 3% is not a large number, but around 20% of lymph node mets is a significant number. So what has been found is that certain characteristics of papillary microcarcinomas, especially in terms of in relatively younger patients, aged less than 45 years, if you have a microcarcinoma, even though you give it a sort of gross size of 1 centimeter, lesions more than 6 millimeter tend to metastasis, tend to lymph node metastasis in a higher percentage of patients. Then if you have any features of extrathyroidal extension or angioinvasion, which is seen in biopsies of papillary microcarcinomas. Those are also features which say that it's possibly a lymph node metastasis is there. And some information to support that if you have a coexistent autoimmune thyroiditis picture along with the papillary microcarcinoma, that seems to be a protective feature in terms of metastasis. So I think it's important when you judge these microcarcinomas, you need to have a good team of radiology to exactly pinpoint which of them are sort of aggressive, the guys who are aggressive within this large cohort of papillary microcarcinomas, and decide on surgeries as and when required. Thank you. That's my.
Thank you, sir. So we heard from Dr. Matthew John that how even microcarcinomas could be aggressive. So the management now, if we have a suspicious subcentimetric thyroid nodule and the surgeon and then we are offering a surgical option to the patients. So sometimes one would offer hemithyroidectomy to see to get an exact diagnosis. And then when after hemithyroidectomy, if one comes with features of comes with the finding of microcarcinoma on the histopathology. So what would be the subsequent advice? Would we go for a completion thyroidectomy at that point of time? Was the question I would like to ask Dr. Rakesh Sahe. There's also a second question I would like to know. Suppose now you have a diagnosis of a microcarcinoma based on an ultrasound and also an FNA. So what would be the advice then?
Yeah, so I think this is a very interesting area, this thyroid papillary microcarcinoma, which is indolent, which is supposed to be indolent and which is less than 1 centimeter, and but you have a diagnosis of papillary carcinoma in that. So this is something which was, in the this was probably a little sort of controversial area in the ATA 2015 guideline also, where it was recommended that you don't even need to do surgery for many of them. So that's the recommendation, that you don't even need to do surgery for this. You just need to do active surveillance, and the active surveillance means that you need to do a good quality ultrasound every 6 months or a year. Every year you do that, and you compare the findings with the previous one and decide based on these features. So as Dr. Matthew John also highlighted very clearly, that there are many of them which are aggressive and they have lymph node metastasis. He said that almost 40% of them have lymph node metastasis. So that's how I mean it could be still be important to tackle them. And most of our colleagues, most of the centers in India, I would still feel they go for surgery because there are limitations of doing this active surveillance, because you don't have patients coming back for follow up, and then the patients are you may not get a good quality ultrasound every time. So these are issues that we have, and so we find it difficult to do active surveillance because we don't know whether the patient is going to come back. And there on the other side, there may be other patient-related factors, like patient may be very anxious once he comes to know that there is a papillary thyroid carcinoma. He may be very apprehensive and may not want to just be on active surveillance, and he want to go for treatment. So those are issues that come up. So interestingly, Matthew John showed some data that he said that there is very high prevalence of lymph node metastasis and central lymph node involvement. Interestingly, there's another study which I was looking at. This study by Ito et al. From Japan. What they did was that they excluded all these high risk features. They excluded those who had lymph node metastasis. They excluded those who had extrathyroidal extension, and then they followed up about 1,200 nodules, and then they found that only about 3.5% of them had clinical progression, and 1.5% of them actually had metastasis. And when they underwent surgery, at the point when they were detected to have these problems, those 4% who were detected to have these problems, they had good surgical outcomes, and they said that they did not have uh, any increase in the risk for recurrences. So they, based on this sort of data, it is suggested that you probably need to just be on active surveillance. But there are limitations to the active surveillance, and I think that's the reason why we need to look at all these factors and decide whether we need to go for surgery or just keep the patient on active surveillance. And coming back to the other patient which you said, when you have a high risk sort of lesion, papillary microcarcinoma, also with the high risk features, then I think the best thing would be to go for a completion thyroidectomy and go with radioactive iodine treatment, and that's the way that is recommended for the high risk ones, or the more sort of where you find that the histological features also suggested you have more aggressive features.
Thank you, sir. So we heard about how there is a discussion on management, whether to do an active surveillance or to go for surgery in these patients, because some of these patients could be aggressive, but most of these patients could be indolent. Now comes the question to Dr. Deena Shrestha on what is the role of radioiodine therapy and suppressed dose of thyroxine following surgery in patients with thyroid microcarcinomas.
Thank you so much. So I think Dr. Rakesh Sai kind of answered both my what you were saying is like 88 didn't even recommend surgery in the first case, right? And the Japanese who did the studies, they found that there's no recurrence. And now actually more and more people are not recommending even for the, because a lot of papillary, if it is papillary carcinoma, we know that the prognosis is good. Even for the macro, when there's more than 1 centimeter, they're not recommended that all of them should have radioactive ablation or should have thyroid suppression, because it also has its own, like the thyroid suppression can have cardiovascular side effects, and the radioactive can have your dry mouth, and so for the subcentric, if it is not aggressive, it is not metastatic, I think that the recommendation is that we should not go for it.
Thank you, Dr. Deena. So with this, we come to the next question is Dr. Matthew John. So now what is the long-term plan for these patients with thyroid microcarcinoma? Suppose we have operated these patients, but then, like Dr. Deena Shrestha said, we would not offer radioiodine ablation, radioiodine therapy, or even suppressive dose of thyroxine to many of these patients who do not have aggressive features. So subsequently, how do you follow up these patients on long-term?
I think we should make it very clear that who is the subset of patients that we are going to just observe according to active surveillance and who is going to get operated, because that becomes an important question. I think Rakesh has cleared that area very clearly, that if you don't have metastasis, you don't have lymph node involvement, you are not in a category of a high risk like a tall cell variant, or again, possibly not multifocal. These are the guys who were actually sort of not, they are the guys who should actually go for active surgery. They don't have high-risk features. And when you go for surgeries, most of them, just like Deena told, will be going for a hemithyroidectomy or a hemithyroidectomy with this isthmusectomy, and if there is no lymph nodes, I think that will be the surgery which is usually done. So once the surgery is over, again, if there are no high-risk features, which possibly are all stage 1 lesions, without lymph node involvement, then there may not be any role for a suppressive thyroxine replacement, especially if they don't belong to a category which is of low risk. You will probably keep the TSH anywhere between 0.5 to 2, that is the low risk category, and follow them up. And being a half, like a sort of hemithyroidectomy, there is again a limited role for thyroglobulin monitoring also in this people, especially if the residue is kept behind. But some people have given cutoffs if TG gradually increases over follow-up, or it causes 30. These are the lesions we should be considering for further follow-up. But it's, I think, a good practice to have if you're keeping back a half a lobe, even in papillary microcarcinomas, it's good to have an ultrasound surveillance of the rest of the lobe on long-term follow-up. But I think if you definitely have an aggressive variant, in terms of histology, or you have a lymph node involvement, then you should go for a combination thyroidectomy. And based on that, you have a dynamic sort of reassessment of the staging system and take it up from there. So that is how you would follow up a papillary microcarcinoma. Thank you.
Thank you.
I think the last part was very important, that if there is a lymph node involvement and if there is extrathyroidal extension, then you need to go for a completion thyroidectomy, and probably those few people would require it.
Thank you. I think we had very excellent discussion on this controversial topic. What we learned is that most of this micro subcentimetric thyroid nodules would be benign, and also even if these patients do have features of malignancy, many of them would have an indolent course. However, there still would be a subset of patients who would still show aggressive courses. I think that is something we have to look up based on an ultrasound features and FNAC, and also do a proper risk stratification, and then subsequently decide whether you're going to do an active surveillance or would offer surgery in these patients. And also we would then make a long-term management follow-up plan on how we would do, whether we would do an ultrasound follow-up for the active surveillance. If you look at the questions which are audience, yes, Dr. Dina wants to add. Yes, please, Dr. Dina.
So that is my question, is that, so are we doing molecular? Like for these, that would be really helpful. So are we ruling in, ruling out? Are we doing those things in India, or what is it?
Rakesh sir, you want to take up the question?
Well,
she wants to know if you're doing any genetic testing in.
Yeah, most of the centers we're not able to do that, and some centers in the country probably are doing it now. Matthew would like to give his experience on this.
No, to the best of my knowledge, in Kerala, we don't have genetic analysis for carcinomas, so we are not doing it.
Otherwise, I think it would be ideal, no, if they have these features, and then you are FNAing it, and you know that they're subcentric, and then that would make sense to do the molecular. Okay.
That will also add to the, I mean, if you have a known mutation, then it probably puts it in a higher risk. Again, in the category of, the risk stratification.
True.
Thank you.
Yeah, thank you, Dr. Dina. I think the audience questions, we have answered most of the questions. I think there's a question on how to proceed when there's a discordance between thyroids and FNA or biopsy. I think this was almost answered. And then again, there was another question, which if a patient presents with the thyroids of 4 and a subcentimetric nodule, say 3 to 4 mm, and the sample is inadequate, how to proceed? I think we've also answered this question. So as far as I see, yeah, I think many times a patient present with thyroid nodule along with subcentimetric nodules with subcentimetric lymphadenopathy, which may be unaltered, unrelated to thyroid, should we go in for biopsy in all these cases? I think, again, we have covered all these aspects. I think we have answered most of these questions there in the chat box. Yeah, so for the rest of, I think we are also running out of time. With this, we would like to conclude our panel discussions, and I would like to thank all the panelists for beautifully carrying out these discussions, and I would like to thank Dr. Sarita Bajaj and Dr. Pramila Kalra for inviting me for this session. Thank you.
Thank you.
Thank you so much.
Thank you, panelists and Dr. Sahana, for a very captivating discussion. So now moving on, we have our next panel discussion on subclinical hypothyroidism in children. So the session will be moderated by Dr. Jibin J. Jacob. Can we have Sir's CV? Yes. So Sir is presently the professor and head at the Department of Endocrinology in CMC, Ludhiana. So Sir has MA in MS and also FRCP Edinburgh to his credit. Sir is also the member of Endocrine Disorders in Pregnancy, Diabetes, and Sir has authored various chapters in books, that is the Endocrine Disorders in Pregnancy, Diabetes in Women, and also the clinical update on the management of diabetes mellitus and complications. He has over 150 national and international journals to his credit. So I now request Dr. Jibin Sir to introduce the panelists.
Thank you, Nanvi, and thank you, Dr. Bajaj, for inviting me. And if you have noticed, the 3 books that I've written with Dr. Sarita Bajaj. So all 3 of them are written with her. So if I have the slides, I'll introduce the panelists. So I think we have a very interesting panel today. We have Dr. Zanai Akanov, who is from Kazakhstan. He's the Chief of Consultative Expert for Endocrinology at the Ministry of Health at Kazakhstan. He's an MD, PhD. And from his positions, you can see he initially worked as a researcher in the Scientific Research Institute of Cardiology and Internal Medicine at Kazakhstan itself. Subsequently, you can see he had quite a number of years of training in Japan from 2005 to 2009. 2011 to 2012, he was a visiting professor at the Ashikawa Medical University in Japan. And subsequently, from 2012, he has been in Kazakhstan, is currently the president of the Kazakh Society for Study of Diabetes and the Chief of Endocrinology Division at the AAA Medical Clinic. So that's Dr. The next panelist is my friend, Dr. Sri Nagesh. Sri Nagesh is a consultant endocrinologist at the Sri Nagesh Diabetes and Thyroid Endocrine Clinic in Hyderabad. He is a DM endocrinologist with 25 peer-reviewed publication, and you can see he's gotten a lot of medals, including the YR Reddy Gold Medal, the SV Rao Swami Medal for passing MD in the first attempt, and the best dissertation for the year in 2017. And he was adjudged the best orator at one of the TISA meeting for his presentation on early insulin initiation. And our last panelist is Dr. Preeti Dabadgaon. And Dr. Preeti is a professor of endocrinology at the SG PGIMS Lucknow. She has more than 50 publications in peer-reviewed journal and more than 20 textbook chapters. Her area of interest is type 1 diabetes, PCOD, and gestational diabetes mellitus. And she's a member of the task force for international evidence-based guidelines for management of PCOS. So I think today we are discussing a little different topic. We usually discuss a lot of subclinical hypothyroidism in adults, and we are all experts because a lot of our bread and butter comes from managing subclinical hypothyroidism in adults. But I think today's discussion is on subclinical hypothyroidism in children. And I think this is also becoming more and more common because a lot of children are tested for thyroid because they are gaining weight, because they feel they're not doing well at school, because they are lethargic, because they are watching too much TV. Many reasons for thyroid testing in children. So I think I'll straight away go into the discussion. My first question I think I'll open this to both Dr. Preeti and Dr. Nagesh, is how common in your practice is subclinical hypothyroidism in children, and what is the prevalence, overall prevalence in our country and outside?
Yeah. Dr. Preeti, like to go ahead, or you want me to start?
You answer, you go ahead, and then
Yeah. Basically, we've actually found subclinical hypothyroidism to be fairly common in our practice. But the levels of TSH which we get are slightly above the upper limit of normal. I won't really put it at considering it as a true subclinical hypothyroidism because that a lot of it is usually associated with obesity. What classically I've observed in a lot of my patients with subclinical hypothyroidism is the ages at which they're presenting with this kind of clinical picture is actually becoming much more common. And we are also seeing a little bit of a randomization bias in our patients with subclinical hypothyroidism because more people are getting tested, more of these abnormal reports are being picked up, and more of them are being referred to an endocrinologist. A lot of times, they're usually referred for a very insignificant rise in TSH. Like if the lab upper limit is around 5.4, they're referred for TSH levels of 5.5 and 5.6. And a common indication why thyroid status is checked in all these children is obesity. If you look at the number of children who come to my OP daily, maybe subclinical hypothyroidism might probably see at least one child with this so-called subclinical hypothyroidism in a day. Prevalence data, I don't think I can actually give you any such prevalence data. Maybe they have such data from Sanjay Gandhi, but otherwise, nationally, India, we don't have a great deal of prevalence data for this so-called subclinical hypothyroidism because differentiating it from a true subclinical hypothyroidism is actually pretty difficult.
I agree with Nagesh that we don't have data. I think we need to do, and if you remove two major chunks as obesity and genetic syndromes, unfortunately, we are a tertiary level center, so we get a lot of Down syndrome children also who get tested. So if we remove these two main categories, then subclinical is just borderline 0.2 or 0.3 milli-IU per liter rise in TSH. Maybe 1 in 10, we get about 10 to 15 new patients every clinic. And say in a 50 per week, we may get 1 or 2 children who would actually be labeled as subclinical. So that is just from our clinic data, which I'd be able to tell you, but we don't have any population-based or a cohort, say we take some children and just do it. it's mostly obese. I think if we do away with testing in all obese children, we won't see so many patients just for a marginally raised TSH.
I think now I'll ask this question to Dr. Akhnov. Is it different in Kazakhstan or is it similar to what we see here in India? Dr. Akhnov, I thought he was with us. Yes, I think you're muted.
Dear colleagues, good evening. Thank you very much for inviting me to the discussion. It's very important for me, and I'm very happy. And I want to explain to you. In Kazakhstan, we have a very big problem. We have 100% of iodine deficiency. So the nearest sea from Kazakhstan is a Black Sea, around 3,500 kilometers from Kazakhstan. So this is the reason iodine deficiency is a big problem. Of course, in the time of the Soviet Union, USSR, we knew that problem. And from Soviet time, we started the fortification of the salt in Kazakhstan with iodine. And of course, we have this special program. And still now, we have this special program. And now we're trying to do our best for our kids. Of course, we make the fortification for salt and flour. But iodine deficiency is still present now. And we still have a problem with this point. From this reason, our government started a special program. The special program is a screening for TSH for every newborn citizen in Kazakhstan. Within first week of their life, we're starting the checking TSH from our kids. Unfortunately, this TSH analyzing only first week. Yeah? Within next 5 years, no any checking of TSH. So this is the reason we have no information about subclinical hyperthyroidism. Is a big problem, we know. But from next year, 2023, we're starting special program for checking TSH level in the age of 5 years old and 10 years old before the puberty. Why? Because we have a special program with our friends from Central Asian region. Yeah? We're trying to compare our levels with Uzbekistan, Tajikistan, Turkmenistan, and Kyrgyzstan also. Because this is the same problem in the Central Asia region. Of course, I agree with Dr. Preeti Dabahal completely, because no any big research of this problem. We need this research. We need, of course, especially in Central Asia, because we have a problem with iodine deficiency. I think that if, for example, Indian society will be organized same research, we will support. We have a budget, we have the program, we have the special equipments. We can make iodine. We can make analyzing iodine in urine. Is no problem. So please, of course, it's very interesting. This is the reason that I take your invitation with my pleasure, because it's a big problem in Kazakhstan. Thank you very much.
Okay, thank you. I think, fortunately, I think iodine deficiency is not a major issue in most parts of India because of the universal salt iodization program that we have going on. So again, my question to Dr. Sri Nagesh is, he very clearly put that a lot of your patients with subclinical hypothyroidism are related to obesity. So is there any specific guidelines you give to those children when they sample the second time? At the time of sampling, or is it, I mean, we know that TSH has diurnal variation. It is very different at different times of the day. Do you give any specific recommendation to children for the second sampling? And do you give a gap of time between the second sampling to say that this is a persisting subclinical hypothyroidism? You're muted. Nagesh, you're muted.
Actually, there are two schools of thought on that. Predominantly, we've always been told that there is a 10 to 20% diurnal variation in TSH, and TSH levels are ideally best done in the morning. But if you looked at the recent data from Newcastle, they're actually going a bit off the beaten track and telling people that 2 p.m. to 6 p.m. is perhaps the best time to check thyroid levels. Because in the morning, you actually have a diurnal surge in the TSH level, which gives you a lot of false positives. This again, data is from adult. We don't have a lot of pediatric data, which if you look at any of the current publications about subclinical hypothyroidism in children, they don't have concrete data. The first sentence that says we don't have a lot of data. As far as more than that, in the Indian scenario where we got so many aggregators and so many labs doing tests online, rather than the time of the test, I think it's the quality of the lab which is more important. And we've been having many issues with that and wide variations. So like all endocrinologists, whenever in doubt, I repeat the test. Time is again dependent. Probably once we do it in the morning in a different lab, we'll perhaps do it in a separate time of the day. Beyond that, for the very mild subclinical hypothyroidism, many times I don't even repeat the test. There's no point testing them when your values are only about 10 to 15% above the lab upper limit of normal. It makes more sense to wait for a couple of months and then repeat the test again later, see that if there's any progression in your TSH levels, and if there is an upward trend, then it always makes it much more sensible to keep evaluate these children further for any causes of subclinical hypothyroidism. Beyond that, I don't give a lot of importance to the time of the test.
Dr. Preeti, the question for you is, we said that obesity is by far the commonest reason for slight elevation in TSH, but let's say you remove obesity, what do you think are the common causes of transient subclinical hypothyroidism and persistent subclinical hypothyroidism that you see in your clinic?
Most common, as all of us know, similar to adults, it's Hashimoto's thyroiditis, where it could be transient and most likely to become permanent later. That is the commonest cause. Then comes, as I said, genetic syndromes, of which Down syndrome is the commonest, and even Turner syndrome. So these are the two common syndromes present, and we really need to be careful and test them more often than we would do other children. Then some drugs, which are anti-epileptics, and they can cause. So drug history is very important. And few conditions of genetic mutations like TSH receptor mutation or DUOX2 mutations, which unfortunately I have never diagnosed in so many years of my practice because we don't do those mutations commonly. But I think these are the most common conditions. And we do have iodine deficiency, at least in Uttar Pradesh, state of Uttar Pradesh, we still do see iodine deficiency disorders, and not as florid as we would have seen, say, 20 years ago, but it's still prevalent in the sub-Himalayan region. So that also is a factor which we have to keep in mind in our population, which comes to our clinic.
Dr. Akno, the question for you is, what do you think? I mean, I have two set of patients. One is what we call idiopathic subclinical hypothyroidism, the other with autoimmune subclinical hypothyroidism in children. What is the rate of progression, in your opinion, to primary or overt hypothyroidism over, let's say, till he becomes an adult?
Actually, generally speaking, in the world, we have the tendency to growing of the autoimmune disease. Yeah, of course, sure. So a lot of the factors show to us that the autoimmune disease, they're increasing year by year. Of course, we can say that autoimmune thyroiditis is one of the leading problem in the common world. But I can say about the Central Asia region. Yeah. So actually, we have a lot of problem with autoimmune disease of the thyroid gland. Yeah? Generally speaking, we have a problem with iodine deficiency. So if we can comparison data between, for example, Europe and Asia or Japan, we can find that, for example, in Japanese population, the level of the antibodies is more higher than in the Central Asia. We have some special research between Nagasaki University and Almaty University, Almaty State Medical University, yes. And we checked, and so we cannot say that Central Asian population have a problem with autoimmune disease. Mostly, the Japanese have a more problem with autoimmune disease. So, and of course, for example, the autoimmune thyroid disease is a big problem, and of course, this problem going grow with the kids and grow into the adult time, and we're understanding that is a problem. But in the Central Asia, we have a good some manners. Every time we're trying to check money, to check budget. Yeah, this is a big problem. If we will make the serious screening program for this problem, we should spend a lot of money. In this case, now after the coronavirus pandemic, so I think that our government have no money for make, for example, even antibody levels. Yeah, there's a big problem because we spend a lot of money. We spend maybe I think maybe $20 billion for the our after pandemic the situation, and so of course I think we should to make the research, at least research first.
Thank you, Dr. P. The question for you is, now one is the conversion to overt hypothyroidism, which we understand may not be that much, but in adults, when we talk about subclinical hypothyroidism, we are worried about their cardiovascular outcomes, their adverse metabolic outcomes. So do you think there is enough longitudinal data to suggest that subclinical hypothyroidism, if it is persistent, untreated, might have adverse outcomes in terms of growth, in terms of cognition, and in terms of long-term metabolic outcomes?
I think there are few studies for growth. But the numbers, again, they are very small, in few hundreds or something like that. And they haven't shown, except for one study, all other studies have shown that growth is not affected by the kind of level of TSHs, because the T4, we know that is normal, which is the primary effect having on growth. So growth is not affected. About neurocognitive, again, there are, if you are talking of, say, subclinical hypothyroidism in early infancy and early childhood, we are on the caution to treat them for this very reason, that they are not affected. So less than 3 years, TSH high, we would generally treat them and take them till 3 years to not have that neurocognitive. But beyond 3 years, again, patients who have been followed up, there are not much significant differences in their IQ points and cognitive function. And in studies where they have tried to treat children, they have also not benefited from that treatment. So, but we don't have data, say, for a decade or 15 years, or when they have become adult, what has happened. These are, say, 2 years, 5 years study, not more than that. Only effect which has been seen is on, I think, cardiometabolic effects, where they have shown that children who have subclinical hypothyroidism do have abnormal lipids, but then does it actually end result in abnormal cardiometabolic health? Again, we really need to have decades of follow-up of these patients to say that this kind of a lipid disorder or lipid abnormality in early childhood did affect later on the cardiovascular health of the individual. So I think we really need decades of follow-up of these children to be able to conclusively say, to have any cardiac event.
All right, so thank you for that answer. Dr. Nagesh, I'm going to ask you now a very specific question. You have a 12-year-old girl child who is just started menarche, who's come with a TSH of 7 for the first time, slightly overweight. What would you do?
Well, the first question I would ask her is she having menorrhagia? If you actually look at the indications, and again, this is data which is extrapolated from adult data, we have very few indications for actually treating a subclinical hypothyroidism, and one of this is menorrhagia. Second one is increased lipids, and again, that question has already been answered by Preeti ma'am, that increased lipids are perhaps not such a major concern in a child as opposed to an adult. The third situation where we would treat somebody is infertility or somebody who's pregnant. In this case, the only thing which would fit in this criteria is menorrhagia. So if she gives a history of menorrhagia in a 12-year-old, and that was the primary reason why she was tested for hypothyroidism, I would perhaps think that a small brief trial of thyroxine therapy is in order, because it has been known that subclinical hypothyroidism decreases your von Willebrand factor levels and also your factor VIII levels, and this can predispose to a slight menorrhagia. The other question is, in case she has been actually tested because she is obese, I would not treat her, because a lot of times pediatricians assume that hypothyroidism causes obesity. It's actually the other way around. Obesity, whenever present, causes a rise in leptin. And leptin has been known to cross the blood-brain barrier, act on the hypothalamus, increase the TRH, and consequently increase TSH. What you are seeing is actually a factitious rise in TSH, which is mediated by the obesity levels. And a lot of times we've actually seen that once these children start losing weight, the TSH level normalizes without any treatment, and this is only a superfluous rise in TSH mediated by obesity. So if the indication is for menorrhagia, I would perhaps treat her. If the indication for doing a TSH was obesity, the only thing I would tell her is to perhaps exercise more and lose some weight and recheck the TSH after 3 months. Do you think this is specific enough?
Yes. No, that's what you would do. I would now ask the same question to Dr. Preeti. Would you do anything different? Would you check antibodies? What would you do?
I think I would check antibodies, but 7, maybe not. You've tricked me by asking me that. Maybe if it is nearer to 10, I would be inclined to do it. Or if there's a goiter, if she actually has a goiter, then would be the reason to check antibodies, or some family history where mother has Hashimoto's or proven Hashimoto's, not just hypothyroidism. Maybe those are the times where I would consider doing an antibody.
I'm going to ask the same question to Dr. Akanov also. What would he do in his clinic?
So anyway, I have another question. Sorry for again for my question. Obesity among the children in India, for example, how many percent of the obesity? Okay, for example, if we check in the special group, of the kids who have a problem with lipid metabolism, we have problem with obesity. So I'm very interested. Okay, for example, in Kazakhstan we have around 21% of the kids in the scholar who have a problem with the weight. Okay, in India, what kind of the percent? Can you explain to me?
Dr. Nagesh, you want to explain what is the percentage of school-going children who are obese in India?
Yeah. How many?
Right now, I think this question will have to be a pre-COVID and a post-COVID. I think post-COVID it will perhaps be closer to 40 to 50%.
For example, okay, in Kazakhstan we have now the problem, sorry for this topic, but in Kazakhstan we have a problem with the pre-diabetes among the children, because we have a lot of the kids with obesity. For example, of course, now I'm listening to your answers, and of course I'm very impressed. So should we make the TSH level in the kids with obesity in the school time? So of course, sure, it's a good idea because we can make the differential. But what do you think about the changing of the culture of the nutrition? For example, Kazakhstan now going very fast, going to the westernization. We have a lot of the problem with we're losing our national cuisine. We're using a lot of the westernization, and now we have a lot of the kids with obesity. So, and of course, we will check, okay, TSH level, that some small cohort of the kids with obesity. But anyway, so I think that the problem with lipid dysmetabolic is not because of the hypothyroidism. It's a lot of the social problem and the problem with changing the lifestyle. I think so. But in Kazakhstan, of course, we have the special program, and from next year we're starting checking the 5 years old and 10 years old before the pubertation. Okay, so we will publish this information because we never check this in the Central Asia region. But anyway, that's a good idea. What do you think? That's my answer. Sorry for my question, the direct question to you.
All right. So I think we are going to run short of time. So I'll just quickly cover. Dr. Preeti, would you want to give us, like for adult hypothyroidism, we have very clear guidelines, whom to treat, whom not to treat. In your hand, can you give us your 5 indications that you would keep for a child with subclinical hypothyroidism whom you would treat?
Goiter with antibody positive, that will be my first one. And pubertal, menarche and menorrhagic. I think these are and Down syndrome. Again, if they are mostly all patients who are antibody positive, I would give them a trial, especially if they have goiter and Down syndrome and menorrhagia. I can't think of any more than that.
All right. Nagesh, question for you.
Nagesh could add 2 more to that.
In adults, we always treat anyone with a TSH of more than 10.
Yes.
Would you consider the same in pediatrics also, among children as well?
Yes, I would. Because the current guidelines, most of the international guidelines would recommend 20. I think 20 is too high. I would in fact keep it at 10. And adding to what Preeti ma'am has said, I'd go with her recommendations. And if the TSH is more, even in the range between 8 to 10, I would perhaps add short stature to these indications.
Okay, so we've got 5 indications. So that's very good. Everyone has agreed that if you have a goiter, you are antibody positive, you'll be more inclined to treat. Nagesh says if you're short statured, you'll be more inclined to treat. Patients with a genetic background, especially Down syndrome, Turner syndrome, you'll be more inclined to treat. And then if the TSH is more than 10, you'll be more inclined to treat. So we need a 5th one to complete our finger. So I think goiter and antibodies, we can take it separately. So we have 5. So I think we have 5 more minutes and we'll see if we have any questions in the chat box.
Yeah.
Okay. So we have a question from Salim. Now, this is a question I don't think I'll be able to answer, so I'm not sure who's going to answer, but screening with NIDCP cluster sampling. Now, I'm assuming this is some kind of screening program going on. Could probably help us, and also recent factor of increased lead and air pollutants, will they affect TSH variation? So this is a very complicated question. So lead and air pollutants, would that be one contribution or a disruptor to the hypothalamo-pituitary thyroid axis?
Could they lead to some superoxide formation and inflammation, the air pollutants? Only that is the reason I can think of. I'm just thinking straight away since I read the question, but haven't read about lead or haven't heard anyone speak about lead pollution causing thyroid dysfunction. Other deficiencies could cause, but haven't heard about it. Nagesh, are you aware?
The lead issue has come down a lot because we're no longer using petrol with lead. The only source of lead right now is paints. Would that be significant? It is true that lead does have a role as an endocrine disruptor, but
yeah,
causal association we have not yet been able to prove. The second part of the question he asked was NIDCP is the National Iodine Deficiency Control Program cluster testing. Like ma'am has said, what the recent National Family Health Survey 5 of 2011 told us was the use of iodized salt is actually going down in the country. In fact, my state and Andhra Pradesh have the least amount of use of iodized salt in the country. We are only at 71%. That's because use of pickles is maximal in these 2 states, and that usually uses uniodized salt. But overall, even in India, the use of iodized salt is only to the tune of 80 to 90%. We do have small pockets of iodine deficiency, but whether they would be as significant as the professor from Kazakhstan has told us is, I think, a bit questionable right now. We have seen that Hashimoto's thyroiditis is perhaps the commonest cause of hypothyroidism. And at this point, I'd like to ask, ma'am, have you noticed a slightly younger age of presentation with Hashimoto's?
Yes, we have.
I've seen children as young as 4.5 presenting with Hashimoto's.
5 to 7, which we never used to see earlier.
Yeah.
5 to 7, we are seeing antibody positive. And surprisingly, I've seen a 4-year-old also with strong antibody positivity with a goiter. And initially we thought it was compensated congenital hypothyroidism, but she had a strong antibody positivity and no family history.
Yes. Okay, so we
Autoantibody.
have last 2 minutes. There's a question that Professor Simon Pierce has asked. I think I'll leave it to Dr. Preeti. Now, because as a pediatric endocrinologist, when these children now, you have decided to start someone on treatment, when you transition to adulthood, would you stop thyroxine, reassess, and then transfer this care over to an adult endocrinologist? Or would you continue somebody whom you have started at the age of 12, would you continue thyroxine long term?
I usually give them a trial for 6 months to a year, even a 12-year-old. I would say very clearly that, look, the TSH is say 10 or 12. I don't know whether you really need a lifelong treatment or not. Let's do it for a year and reassess the situation at that time. If antibody is strongly positive, again, it gives me still a chance to see that the child would really, does she need that therapy? Because everything comes with a price. So it's better to be sure and give a lifelong therapy. So I would do it.
All right. So Nagesh, any last words?
If it is about this particular case, I would not perhaps do it at 12. I'd like to slightly differ from Preeti ma'am. I'd perhaps do it at 16. And again, my assessment of this would be dependent on the thyroxine dose. If somebody is on a dose of 100 or 75 thereabouts, there's no question of stopping. If it's 50 or below that, perhaps a trial is warranted in the absence of antibody positivity. And once it's completed, do it.
And Dr. Akinov, any last words before we hand it over back to the organizers?
Well, you know, there's a big problem. Actually, generally speaking, it's a big problem. If we're looking for example, for Kazakhstan or Central Asia countries, for us is a problem. And of course, we should do something, and we will. Fortunately, I hope that near future, I will present our data to you. Thank you.
So thank you very much. Thank you for the panelists for covering.
Can I just add 1 minute?
Yes, yes.
I thought we were talking of that 12-year-old girl who had attained menarche. Would I stop at 16? So she had completed puberty. So I said, I'll stop at 1 year. But otherwise, if she's pre-pubertal or going through puberty, yes, surely that we will reevaluate her when she finishes puberty. And so I thought we were talking of that 12-year-old girl still.
All right. Okay. So thank you very much. So we've had a very interesting discussion, and back to the organizers. Thank you.
Thank you.
Thank you.
Thank you, panelists and Dr. Jubin sir, for a very gripping panel discussion. So now proceeding to our last and the most awaited session, that is the talk on Graves' disease, unmet needs. So the session will be chaired by Dr. Subankar Chowdhury sir. So I request Sir CV to be put up. So Sir is presently the Professor and Head Department of Endocrinology at Academia and SSKM Hospital, Kolkata. His areas of interest are gut microbiome and gestational diabetes, pathogenesis of Graves' orbitopathy, and biology of fat in different body compartments. He's had various positions held. He's the member of Subject Expert Committee, CDSCO, Government of India. He's the founder patron of the South Asian Federation of Endocrine Societies. He's the immediate past editor-in-chief of IJEF. He's the immediate past president of the Endocrine Society of Bengal. He's the past president of the Endocrine Society of India. He has over 207 publications in the peer-reviewed journals. So over to you, sir, to introduce Professor Simon Pierce.
Very good evening. Am I audible?
Yes, sir.
You're audible, sir.
Great. So it's wonderful to be part of this Thyroid Day observation program that Indian Thyroid Society has opened. We do have a lot of issues related to thyroid problems, from treating awareness to proper diagnosis to management and so on. We are indeed very happy and lucky to have Professor Simon Pierce we hired to speak to us on if that is Graves' disease, which is the commonest cause of hyperthyroid. He will talk to us about the unmet needs. We do have different, but possibly none of these actually meet the qualities or characteristics of an ideal form of treatment. So he is at Newcastle University in the UK. He is a president of session from 2020 to 2022, editor-in-chief of European Thyroid Society for Endocrinology Program Secretary 2016 to 2018, as a panel reviewing guidelines for care of patients with benign thyroid disease 2018 to. So the floor is yours, Professor Simon Pierce.
Thank you very much for the kind invitation. I hope you can hear me okay. You can see the slides?
Yeah, we can see the slides.
Absolutely.
Okay. Well, it's a real pleasure to talk to you on World Thyroid Day. And we've all had a busy day already thinking about the thyroid. So I'm going to talk today about Graves' disease, unmet needs, and new therapeutic options. Just wave at me if you can't hear me for some reason, or the slides don't move on. Oops. Let's try that. So I have done some consulting relating to this work, but it shouldn't affect, it doesn't influence what I'm saying about these. So the content I'm going to talk about today is why develop novel therapies for Graves' disease? What are the unmet needs? And then we've got two basic categories of new therapies, those that are specific for the TSH receptor, and I'm going to talk about two of those, and those that are immunomodulatory. And there are three of those, although one actually acts on the TSH receptor. So this is kind of looking into the future of what treatments we might be using for Graves' disease in another 5 years' time, on top of the ones we already have potentially. So we're already very familiar with the current therapies for Graves' hypothyroidism. We have the antithyroid drugs, methimazole, carbimazole, or propylthiouracil. Patients like these treatments is just taking a tablet. But the problem from our perspective is we know when we start these people on treatment, it's only really going to work in about 50% of them. And after a couple of years or 3 years, about half the patients will still have a relapse of their hypothyroidism, and they will need to consider definitive treatment either with radioiodine or thyroidectomy. These are both highly effective treatments, but they both are going to leave the patient on lifelong levothyroxine therapy, and they each have their own pros and cons. So, of course, for thyroidectomy, a general anesthetic and a scar in the neck, and for radioiodine, it may exacerbate or precipitate thyroid eye disease. So none of these treatments is ideal for a patient, but it's often a conversation between the doctor and the patient of which is the preferable treatment. This is an important thing, long-term outcome. So you know, if you had Graves' disease, maybe the thing you should consider most is how you'll be feeling in 5 or 10 years' time. And there's actually not much information on that, but this is a study looking at quality of life 6 to 10 years after the first diagnosis of Graves' disease. And these are patients from Sweden. And so this is the quality of life symptoms here, which is from the so-called Thyroid 39 scale, which was developed by Torkel Watt in Denmark. And you can see we have patients who received radioiodine, surgery, or methimazole in this population, and they're compared to the healthy population in the black line. And so nearer the center is less in the way of symptoms. And these are things like hypothyroidism, hypothyroid symptoms, cognition, anxiety, depression, emotional susceptibility, even sex life and appearance. And so, in fact, for all domains, patients who were treated with methimazole do a bit better than patients treated with the other two modalities. But if you choose between surgery or radioiodine as definitive treatment, quality of life is better for everything except for appearance if you have thyroid surgery. So radioiodine is probably the worst treatment in terms of long-term quality of life. Surgery next, but methimazole is the best. So if we're going to make more treatments, we should maybe be thinking about more medical treatments. So these are the unmet needs for patients with thyroid disease, so Graves' disease. So firstly, thyroid eye disease, this is very familiar to all of us, and it's so obviously associated with poor patient satisfaction that we don't really consider this to be something interesting. We know people with thyroid eye disease do badly. There are persistent cosmetic concerns in many people, leading to low self-esteem, poor quality of life, as well as imperfect visual function, including loss of sight. And although it's very rare for patients to go completely blind due to thyroid eye disease, if they have optic neuropathy, they will often lose a line or two of visual acuity on the Snellen chart. And this isn't often acknowledged by ophthalmologists. So, of course, patients with severe hypothyroidism, we can sometimes predict the day that a patient first comes to our clinic, if they have a free T4 of over 100 picomoles per litre, or if they have a huge goiter, or their TRAB antibodies are 10 or 20 or 30, many times the upper limit of the normal range, that however long we treat this patient with antithyroid drugs, they're never going to be cured by antithyroid drugs. So we should be looking at ways where we can improve the outcome for these people, but because we already know it's bad the day they present, and we can be hopeful, but being realistic, this is rarely, this sometimes becomes a futile situation. You can make the patients feel better, of course, over weeks to months with antithyroid drugs, but it's very rare for a patient like that to get remission. And then the thing we don't talk about very much is young people. And if we treat patients less than 20 for 2 years or even more with antithyroid drugs, the remission rate is generally less than 25%. So young people tend to do rather badly with antithyroid drugs. And this actually has quite a bit of morbidity in terms of delayed diagnosis. When they're at school with uncontrolled hypothyroidism, they don't learn very well, and they have poor school performance, which can actually affect their life chances because they don't get the exam results they need to pursue a good career. We also don't tend to think about this, but this is a Danish study showing increased suicide rates, particularly in patients with Graves' orbitopathy. So this was many thousands of patients, including just under 4,000 with Graves' orbitopathy, and tens of thousands, more than 10,000 with Graves' hypothyroidism. So this is the odds ratio for suicide compared to the background population, matched controls, about 1.2, which wasn't significant for hypothyroidism alone, but close to threefold suicide rate for patients with Graves' orbitopathy. So this is a really serious problem. It might not be many people, but this is a real worry. So how could we do better for these patients? And I'm just going to discuss broadly 5 treatments over the next 25 minutes or so, what's around the corner. So firstly, TSH receptor manipulation. And just to remind you that Graves' disease is caused by these TRAB antibodies. And this is a TSH receptor here, a G protein coupled receptor. And by some strange freak or chance of structural biology, you get an antibody, an immunoglobulin that your immune system makes that mimics the shape of TSH. And so it comes in and the receptor thinks this is TSH, and it activates, causing release of the thyroid hormones and also stimulation of thyroid cell growth, leading to goiter. And so this is the underlying mechanism in all cases of Graves' hypothyroidism. And so if, as well as stimulating antibodies in Graves' disease, you can occasionally get blocking antibodies. And the group from Cardiff, RSR, cloned a blocking antibody called K170 from a patient with Graves' disease and high titers of blocking antibodies. And this antibody appears to block the stimulatory antibodies from binding to the receptor. So this just shows you the data from rats. M22 is a stimulating monoclonal antibody, also cloned from humans. And so when you give this to a rat, within 24 hours, the rat has hypothyroidism. The total T4 goes from 25 to 70, and that goes away over 2 or 3 days. So with the M22 stimulating antibody, but if you give a mixture of M22 and K170, the blocking antibody, there's absolutely no rise in total T4 at all. So this is a really powerful blocking antibody, and it really shuts down the receptor so that it's, if you like, it's immune to the effects of stimulating antibodies because it just binds it up. So they've now very recently finished a first-in-man study with this K170 blocking antibody. They used 5 doses of treatment from 25, 50, 150 milligrams were the top doses. The bottom 4 doses were given by intramuscular injection and the top 2 by intravenous injection. And what's this just shows you the pharmacokinetics. A single dose of antibody, 50 or 150 milligrams, still has very detectable levels 100 days later. So you could potentially give this once every 3 months or so as a treatment because it hangs around in circulation for a pretty long time. I'll just move the screen on manually. So this just shows an example from one of the patients in their study given the highest dose, 150 milligrams of K170. So this patient started off mildly hypothyroid with a free T4 of about 35 or 32 picomolar and a free T3 around 10. The patient had a single dose of K170, 150 milligrams, and the free T4 drops like a stone. 7 days later, the patient has a free T4 that's actually low. It's about 7. So the patient became hypothyroid over a week following a single dose of this antibody. The TSH rises as well, and the patient goes hypothyroid. So this patient was already treated with propylthiouracil, so that was stopped, but the patient still didn't normalize the TSH, so the patient had to be started on levothyroxine. The patients remained euthyroid on levothyroxine for the next 100 days. So these are pretty powerful treatments that that last and could really have a lot of potential in Graves' disease. So I'll just recap this treatment. It's a blocking TSH receptor antibody cloned from humans. Phase 1 trials were completed on 18 patients with Graves' disease, and single dose of 150 or 50 milligrams resulted in hypothyroidism. There's also in this paper preliminary evidence of improved thyroid eye disease, which, to be fair, might not be too unexpected given the mode of action, and all the doses were well tolerated, so these patients did really very well. So the next thing is small molecule antagonists. If we can block the TSH receptor in the extracellular domain up here, and stop it activating, we could also stop the 7 transmembrane domains. So the way the receptor works is those 7 transmembrane domains switch, they just pivot when the receptor is liganded by the TSH or the TRAB stimulating antibodies. And so we can design drugs that sit in this transmembrane domain and stabilize it. And so, if you like, it's like putting a screwdriver or a spanner in the works. And so these transmembrane domains can no longer pivot and activate the G protein attached to the TSH receptor. So could we design something like that? Well, there are 3 compounds, at least 3 compounds in preclinical testing. 2 in the USA and 1 in Denmark, 1 in Germany. So the problem is these need to be very specific for the TSH receptor because the other glycoprotein hormone receptors the LH-HCG receptor and the FSH receptor could also be liganded in a very similar way, because these are antagonized in a very similar way, because these receptors has a very similar molecular structure. And so the three compounds are being developed by Krause in Berlin. That's this S37A compound, Marvin Gershon, Gorn, and Terry Davis in the NIH and in New York, respectively. And so this shows the inhibitory action of these compounds on the TSH receptor. These two, S37A and ANTAG3, that's the German compound, that's the NIH compound, look good. K14 looks to be the strongest inhibitor, but unfortunately, this also inhibits the LH-HCG receptor and the FSH receptor. So you would predict this K14 molecule shown down here would have some reproductive toxicity on the ovaries or on the testes, whereas these other two look much cleaner and so might go forward to testing in man. I'm not aware of any of a first-in-man study being completed with these molecules yet, and because of course G protein coupled receptors is a very large family of receptors, there's still a lot of potential promiscuous effects that these molecules could have on other receptors. But this is certainly an area, these drugs would be predicted not to cause the same side effects as antithyroid drugs. They shouldn't cause agranulocytosis or rash, and so potentially if you can develop a clean enough compound, you could start someone on this treatment, and you could have it for the rest of the person's life. So I'll move on to the next subject. So I've opened the questions now, and we'll just move them out of the way. There we go. Okay, so this is a different subject altogether. This is tolerogenic peptides, and this is really an immunomodulatory therapy, but it's going to act through the TSH receptor. So this isn't a very familiar subject to endocrinologists, but to our colleagues in the allergy clinics, the desensitization is something they do all the time. So the patient has an abnormal allergic immune response to peanuts or to wasp venom or bee venom in a bee sting, or perhaps to milk, something like that. And an allergist will give a patient a very low dose of this protein or peptide and repeat this small and increasing doses over a period of time. And so this just shows you on the bottom a trial that was done with immunotherapy for bee stings. All the patients had severe reactions, most of the patients had severe reactions, grade 3 or grade 4 reactions at the start of the treatment, but after treatment, they only have these grade 1 reactions shown in the white, or mainly they have much milder reactions. And so this is an effective way to dampen down the immune response and produce tolerance to the antigen in these allergic conditions. And this is thought to work by inducing IL-10 secreting regulatory T cells in the circulation, which help. So could this be used in endocrine diseases? Well, very interesting. There's a nice trial in type 1 diabetes. So this trial took adults with type 1 diabetes and treated them within 3 months or so of the first onset of 100 days from the diagnosis of their diabetes. And they gave a pro-insulin peptide either at high frequency every week, every 2 weeks, or placebo. And then they evaluated the patients every 3 months for a year. So the results of this study, really interesting study, I have to say. So placebo patients are shown in the black square on top here. So this is change in insulin dose over the first year of treatment. The patients who received placebo had a steadily increasing insulin dose, as I guess their pancreatic beta cells died off, and similarly their HbA1c also rose over the first year of treatment. Whereas patients who received the peptide therapy, their disease has been modified. Okay, the immune response has been modified, and actually their insulin requirements remain static for a year, which proves, if you like, their beta cell destruction had been arrested. And in fact, some of them had slight improvements in their HbA1c, In fact, more in the low frequency, the 2 weekly dosing than in the 1 weekly dosing, which is kind of interesting. And so if you like, this is proof of concept that a peptide therapy like this can modulate the immune response in a patient with an autoimmune disease as well as in an allergic disease. So could this actually work for thyrotoxicosis for Graves' disease? So I've been working with this company called Apitope since 2012. And what they did was, this is TSH receptor here on its side. So this is the extracellular domain, and these are the transmembrane domains. And so this just shows you the protein, or is a schematic of the protein sequence from the minor terminus to the C terminus of the receptor, and the A subunit, which we already knew the antigenic target of Graves' disease for the antibodies is in the extracellular domain of the receptor. And this just shows you these so-called immunodominant peptides that were isolated by Leslie de Groot's group and Basil Rappaport's group in the late 90s, early 2000s, the position of these in this extracellular domain. And really working with Apitope, we confirmed 2 of these peptides are the immunodominant ones. And so the idea is we can use now these immunodominant peptides and see if we can desensitize the patient to these peptides. And there are only two real properties of these peptides. They have to be highly soluble and they have to be not processed by the immune system. In other words, the immune system will cleave certain peptide sequences, and these have to be uncleaved peptides. And so these are located up there in the leucine-rich repeats where the antigenic area of the receptor is, and we give these by intradermal injection. So this just shows you the trial we did, first in woman trial, because this mainly affects women. In fact, we recruited 12 patients, 11 of them were women in the study. So we screened the patients and they get a dose ramp of the peptides, starting off at a very low dose, 25 micrograms, going up to 800 micrograms every 2 weeks. And then they get 5 doses of the full 800 microgram dose. And then we evaluate their hypothyroidism at the end of the study. So this just shows you the serum free T3, and we classified the patients into responders or non-responders by what their free T3 and free T4 did. And actually the results for free T4 map exactly onto this. There's really no difference. So out of the 12 patients, 2 patients didn't really engage with the study very well. 1 patient just had 1 dose of the peptides and didn't like it. Another one had the full dose ramp up to 10 weeks. So they got the target dose. And even though their free T3 was dropping and the free T4 was dropping, they decided not to proceed. They still had, they still were hypothyroid at this stage, and they felt their symptoms were too much, even though the free T3 had dropped. So 2 patients were excluded because they didn't have the full course treatment. 3 other patients, their free T3 and free T4 rose during the course of the study to the last dose. And so those are non-responders. So that leaves 7 patients whose free T3 improved. So 7 out of 10, it improved to the 18 weeks. And out of those 7, 5 had a free T3 within the reference range at the end of the study. And this was durable in the majority of patients, even after the treatment was stopped for a month. So this shows we're modulating the natural history of Graves' disease. TRAB antibodies also came down in most patients, including some patients who didn't have a clinical response. So this patient's TRAB antibodies were clearly dropping, even though their thyrotoxicosis was worsening, which is curious. These are immunomodulatory self-peptides. They're so specific, they're just specific for the TSH receptor autoimmunity. They're only expected to work in Graves' disease. There's no risk of immunosuppression, so no risk of infection or anything horrible like that. And it appeared to have about a 70% response rate in our patient group, and 5 out of 10 normalized their free T3. So this was just the first study we've done, and we're planning another study which should get going during during 2022 of these peptides, because we may need to change the dose around a bit, for instance, to get more people responding. So in this case, these are tolerogenic peptides that work by inducing IL-10 secreting regulatory T cells. And so these TSH receptor peptides that will bind the MHC class II and have a tolerogenic effect on the lymphocytes. But in other diseases, in particular cancer, they're looking to kill off cytotoxic T cells, and this could work for autoimmune disease as well. So instead of just putting the peptide in there, you put a peptide which is conjugated to something toxic, and this will be a class 1 MHC peptide. And then these cytotoxic T cells that are coming in and destroying the tissues, they'll be targeted because they'll recognize the disease-causing peptide, and you could kill them off. And so you would skew the balance of, if you like, cytotoxic to regulatory T cells, so the immune response becomes regulatory again. So this is an area which is in development for some diseases as well. So those are, if you like, TSH receptor specific therapies. 2 of them work kind of directly by blocking the receptor. The other one works by creating immune tolerance. So specific action at a critical point of the pathogenic pathway of the disease. No systemic immunosuppression, they're safe from side effects, but certainly the first 2 may not influence the underlying autoimmune process, but the peptides certainly would do that. So I'm going to move on and talk about 2 other approaches which are immunomodulatory, and hopefully we can do this in the last 10 minutes or so of this talk. I hope I'm not going on too long. So first of all, blocking antibody recycling. So it turns out that antibodies are recycled by the body all the time, and who knew that? Well, if you'd ever given intravenous immunoglobulin in your clinical practice, maybe you already knew this, but it turns out that intravenous immunoglobulins have beneficial effects in many autoimmune diseases, just not really endocrine ones. Idiopathic thrombocytopenic purpura, the hematologists use this, myasthenia gravis, Guillain-Barré syndrome, and various other immune disorders. So how does this work? Well, it turns out that there's a receptor, the neonatal Fc receptor, and it's called the neonatal Fc receptor because one of its physiological roles is it transfers antibodies across the placenta into the baby. They don't just transfer passively. This receptor actually kicks them out of the mother and puts them into the baby. But it also is present in the vascular endothelium and in lots of macrophage and dendritic cells in the immune system. And it's constantly recycling the immunoglobulins in your blood, and that's its specific job. It also actually recycles albumin as well as the immunoglobulins. So you can see this, the receptor's this little flag here. And so this is a circulation. It's taking in antibodies non-specifically, and it checks them out. Are they clean? Are they damaged in any way? And if they're good, it recycles them back into circulation. But if the conditions aren't right, or the antibodies are damaged or unfolded, or the glycosylation, the carbohydrates on the protein chains is damaged, or it's all bad, it degrades them, and so they don't get recycled back into circulation. And so what happens when you give high doses of intravenous immunoglobulin, and that's 5 or 10 grams of intravenous immunoglobulin, is this pathway gets overwhelmed, and lots more antibodies get degraded in the lysosomes, and so they're not recirculated out. So what's clever is they've now made, instead of just overwhelming the system with grams and grams of immunoglobulin, they've made a series of very specific antibodies that bind to the FcRn receptor and stop it binding the immunoglobulins for recirculation. So now all the antibodies that are bound are just degraded, and so this drops the serum immunoglobulin concentrations, including the pathogenic antibodies causing your disease. So this just shows some data from myasthenia gravis, because this is one of the main targets for this disease, for these FcRn neonatal Fc receptor compounds. So this just shows you these are 6 doses of the compound. The serum immunoglobulin concentrations drop by 60%, even after 3 doses, and they drop further after a further 3 doses. So you'd expect the TRAb antibodies to drop to the same degree, 6% down. These are specific anti-acetylcholinesterase receptor antibodies causing the myasthenia gravis. These also drop after doses of antibody down to less than a reduction in 70%, so that looks pretty good. And this is MCG, is the myasthenia gravis clinical score. So this is how are the patients. Well, on the highest dose, the patients start to get better. They have a 10-point drop from baseline, which looks pretty good. although I'm in no way a myasthenia expert. But these patients certainly get better. And this just shows you the same thing for idiopathic immune thrombocytopenia. So it's easier for us, maybe easier disease for us to understand. So on the highest dose, 20 milligrams per kilogram, there's a patient here. He starts off with a platelet count of 20. He has a single dose of 20 milligrams per kilogram, and a week later his platelets are 140. So this is a life-saving treatment if you're bleeding to death with a platelet count of 20, and a week later your platelets are 140. This is very dramatic treatment, and so these drugs are going to have a really good application. And so this is the first in class. It's called rozanolixizumab, and this is coming onto the market pretty quickly for these indications. So actually, as well as rozanolixizumab, there are several more in development or in trials. Nipocalimab, I'm not going to say them because they're difficult to say, but the one that's in trials for Graves' disease is called batoclimab. Okay, so this has already been in phase 2 trials in Graves' disease, and they're starting a phase 3 trial, I think, this year. So pooled intravenous immunoglobulin overwhelms this immunoglobulin recycling pathway when you give 5 or 10 grams. But we can give milligram quantities of these FcRn antagonists and make this a specific high affinity interaction. Reduces serum immunoglobulins by 85%. That will give you a slight risk of infection, but it will also potentially have a very dramatic effect in Graves' disease and other treatments. So I'm kind of really excited about these treatments because they just look like they have such quick effects and such dramatic effects. You know, imagine making your patient euthyroid in a week with these kind of antibody treatments. So the last thing I'm going to talk about is B cell therapies, and you may already be a bit aware of these. That B cells, obviously, in Graves' disease, these are driven by the antibodies which come from mature B cells, and so by knocking off the B cells, by specifically targeting them, might be a way to modulate the immune response. And so CD20 is expressed on most of the B cell precursors and mature B cells, and this is targeted by rituximab, which is already had some trials in Graves' disease. And in fact, we use it quite routinely now in thyroid eye disease. So this just shows you the very first data on this from Laszlo Hegedus's group in Odense, Denmark. And you can see these patients had Graves' disease. They were treated for 100 or 110 days with methimazole. And then they were either given rituximab, 10 patients, or they weren't given rituximab, a further 10 patients. So these patients refused to have it. These patients accepted the treatment. So it wasn't randomized, but that's just how it went. So the patients who had 100 days of methimazole to lower euthyroid, they all relapsed within about a year of that treatment. Whereas out of the patients who had the rituximab as well, 4 of them remained euthyroid for more than 3 years. And so this is first evidence. This was the first evidence that these B cell therapies could really modulate the immune response in Graves' disease. So we talked about the unmet needs. Young people is one that we're particularly concerned about in our hospital, because I work with an excellent paediatrician, Dr. Tim Cheetham, and we constantly are worried by these youngsters with Graves' disease. So in the UK, rituximab is routinely given now for young patients with juvenile arthritis. Over the age of 12, they can be eligible for rituximab treatment. So we thought maybe we could use this in young people with Graves' disease as well, because there's a good accumulated safety data in children. And this just shows you the data from 8 or 9 different trials or studies of antithyroid drugs in pediatric Graves' disease. You can see after 2 or 3 years treatment, the remission rates are like 20%, 25%, 30%, 38 or 40% is as good as it gets. But this large retrospective study, 700 patients treated for 4 years or less with antithyroid drugs, only 25%, and that's about average. So that was what we had in our sites, and we just did, if you like, early phase study to see if we could find a signal for activity. So we took 20 youngsters with Graves' disease aged between 12 and 20, and they had carbimazole in the normal way in the UK for 12 months, but they also received rituximab 500 milligrams at the start. and then they stopped both. The rituximab is a single dose only, and they had the carbimazole for the usual 1 year treatment, although in children we'd normally treat for 2 or 3 years minimum in general. This was the study design. And so what happened was after the rituximab, 13 were in remission, so that's nearly 50%, and 14 had relapsed. And what we thought the natural history would be is actually that probably 20 or 30% would be the best remission rate we could get. So working with a statistician, we're able to predict a critical number. And if more patients above that were in remission, it was a highly significant finding, signaling that this treatment looks like it is modifying the natural history of Graves' disease in these children. So before we started the study, the statisticians, they didn't tell us this number, but they worked out that if we had more than 9, it would be a significant improvement. And really, if you can imagine it, in adults with Graves' disease, we tend to think 50% will remit with antithyroid drugs. And so we essentially, by adding in the rituximab, we converted these children into adults in terms of their remission rates. We improved it. So there are several other B-cell depleting agents that are in development or available on the market, targeting different B-cell molecules. And I'm sure we're going to see a lot more of these drugs in the future coming through. So to summarize my talk, there's definitely unmet need in Graves' disease, and we're all familiar with that. We see it all the time, and we actually often don't bat an eyelid about it. We just get on and do our jobs and understand that some groups of patients will do badly. But we should be looking to improve that. So I've talked about these TSH receptor-specific therapies, K170, the blocking antibody, and these 3 different small molecule antagonists. There may be many more of these, because in some ways it's an infinite molecular array that could inhibit the receptor. And then 3 different immunomodulatory therapies, the tolerogenic peptides, which in some ways are the cleanest of all these treatments, blocking antibody recycling, and then the B lymphocyte depleting approaches. So I think if we look at this field in 5 or 10 years' time, we'll still have antithyroid drugs in use, we'll still have radioiodine and thyroidectomy in use, but we'll probably have something else, and we'll be targeting that at patients who currently do badly. We're not going to put our surgeons out of business. Patients will still need to have thyroidectomies for sure. And this new treatment, it'll have an upside and a downside, just like these treatments we have already. But we will be able to offer patients something different, perhaps in conjunction with antithyroid drugs, to improve their remission rate. So I just want to thank people I work with, particularly Tim Cheaton, a paediatrician, but many other people in my research group, and the collaborators who helped with the epitope study as well. So that's all I've really got to say. Thank you for your attention.
Thank you. Thank you, Simon. That was wonderful, opening the doors to a whole new world of potential treatment, new treatment for Graves' disease. Of course, it needs to be seen whether they significantly improve outcomes, are better in terms of less adverse effects and things like that. But of course, it's good to know that there's so many new things are there on the anvil. So you have also thrown light on a relatively less known fact, that is, I wasn't so much aware or conscious, that suicide rates are significantly higher in Graves' disease, and especially in Graves' orbitopathy. And actually, in those with Graves' orbitopathy, many a time we are less concerned because the treatment that we have to offer has got so much of adverse effects that we do not offer. But from the patient's point of view, that is significant cosmetic issue. And we sort of tend to put it under the rug, saying, no, you don't need treatment. She needs, or he or she needs treatment, or we are not able to provide the right sort of treatment. So thank you very much. So we have a couple of questions I have seen. One is, I don't have a name to either of the questioners. One is it wise to follow a male patient with Graves' orbitopathy with TRAb levels? I do not know exactly what means. Would you like to take up this question?
Well, we would always measure TRAb levels in a patient with Graves' orbitopathy, mainly just to confirm what we're dealing with and to decide what to do with the treatment. Often the patient's on antithyroid drugs, and we would be very reluctant to stop antithyroid drugs in a patient with orbitopathy if the TRAb levels were high. You know, if the orbitopathy had burnt out after 1 or 2 years and the TRAb levels were negative, we might consider stopping antithyroid drugs. But if those TRAb levels remained high, we definitely wouldn't. So yes, so we would follow TRAb levels quite closely if the patient's on antithyroid drugs. If the patient's not on antithyroid drugs, it's debatable whether that's a worthwhile thing to do. You know, like we might do it once as a diagnostic test just to make sure that this is Graves' orbitopathy if there's no other sign of thyroid disease, for instance. But yeah, we tend to measure it at least once on every patient with orbitopathy just to be sure. And particularly if there's something a little bit unusual about the orbitopathy, for instance, if it's unilateral or there's not much in the way of eyelid signs. In other words, if there's upper lid retraction and it's symmetrical, it's almost always Graves' eye disease. But if there's not eyelid retraction and the features are a little atypical or unilateral, then we might want to be more confident that it's the right disease.
Right. And there's another question. It's related to the use of immunomodulator drugs. So how long can we use for management of Graves' orbitopathy once again? Of course, we do know it can have a self-limiting course. But it's for you, Saman.
Well, that's exactly right. It has, in everyone, it has a self-limiting course. The question is, does it self-limit and the patient has this thyroid optic neuropathy and the patient ends up blind at the end of it or not, or with severe, severe dysmotility and double vision. So, we have lots of treatments for immunomodulatory treatments for thyroid eye disease. We start off with pulsing methylprednisone every week for 12 weeks, 500 milligrams for the first 6 weeks, and then 250 milligrams for the second 6 weeks. That's our standard introduction treatment for a patient with active thyroid eye disease, which is moderate or severe, for instance, causing them diplopia or severe surface symptoms and cosmetic problems. So after that, we would move on to mycophenolate, and we'll often treat people with mycophenolate for 6 months to 12 months, depending on the response. But, I say to patients with mild eye disease that this disease will improve spontaneously, whatever we do in general. And so treating for more than a year with mycophenolate doesn't really seem justified to me. And so we tend to wean it off after 6 months or perhaps a little bit longer, but we're thinking about that at that time. And then the B-cell therapies, we do routinely use rituximab in patients with thyroid eye disease, particularly the patients who we want to spare repeated doses of steroids. So perhaps patients with heart disease or patients with type 1 diabetes, we will probably start off with 2 or 3 doses of methylprednisone, but then maybe we'll give them rituximab with the 3rd dose. And because once the B cells are depleted, that treatment pretty much works in everyone for at least 6 months. And in many people, it lasts for a year or longer before the B cells come back. And so a single dose of rituximab is good for 9 out of 10 patients with thyroid eye disease. And because, if you like, it's a monophasic disease, once it's gone, it rarely comes back. It can come back, but it's, 1 in 20 cases comes back, let's say, after an initial active phase. So a single dose of rituximab is a pretty cost-effective treatment nowadays because the price has come down a lot.
Right. Can I ask you a sort of personal question in terms of what you do in treatment of Graves' disease? And I've seen a great deal of variability amongst physicians. I feel I personally provide them all the 3 broad options currently available: medical, surgical, radioactive. But somehow or the other, most patients do eventually come down to agreeing to medical treatment. And I feel maybe there's a certain way that I present, that's why they agree. But the physician, maybe the endocrinologist, other endocrinologists in the city, they routinely use radioactive iodine maybe almost as first-line treatment. So what is your approach? Is it medical, radioactive?
Yeah, so I mean, we have in our clinic, we have, if you like, a pathway document, and we really would define our patients as having mild, moderate, or severe Graves' disease on the first day they come. And so these are purely, if you like, operational criteria. If the patient has a TRAB level of over 10 and a free T4 level of over 50 picomoles, we say they've got severe Graves' disease. And so I'll have a conversation with that patient that says, we'll start you on antithyroid drugs, but you're probably not going to be cured by these, and we would recommend that you go for radioiodine treatment or surgery within the next 6 months. Once you're feeling better and you've started to gain a little bit of weight, because these patients aren't in a good position because they feel bad when they first present, and so they might not make the best decision, and they might need to hear this whole story again. We've audited this in our clinic. If they have those criteria for free T4 over 50, TRAB over 10, then there's only 1 in 5 chance they'll get a remission with antithyroid drugs. So I push them to surgery or radioiodine, not always successfully. Some of them still say, I'd like to stay on antithyroid drugs for a year or 18 months, please.
Right.
And then we have patients with moderate disease who have a free T4 between, say, 30 and 50 and TRABs less than 10. And we'll often use a block and replace regimen for those patients, starting off with carbams or 40 milligrams and adding in levothyroxine. But if they get a side effect of the carbimazole, then we'll push them towards radioiodine or surgery. And then we have a group of milder patients with free T4 less than 30 who we tend to recommend titrated carbimazole to as the way to go. I mean, in the UK, we're thinking about NICE. NICE have recommended that radioiodine should be the first-line treatment for most patients with Graves' disease, unless they have a very high chance of remission with antithyroid drugs. So for the moderate or severe groups, then NICE say give radioiodine, and it's quite a positive thing they're saying. The problem is there's actually quite a nice Dutch paper you'll be able to see. Some patients, whatever you say to them, won't agree to have radioactive iodine, and that may be as many as 40% of patients have at least in Holland, in the Dutch population, have an intrinsic distrust of radiation and won't be irradiated whatever you say to them. So this paper is called something like a critical choice experiment. And so patients say, what would you accept, as the side effects of the treatment? And some people just won't have radioactive iodine, which is interesting.
Right, great, thanks. And Professor Sarita Bajaj, your point to make.
Yeah. Good evening, Simon. Thank you. Really enjoyed your presentation. A very futuristic approach to what's in the pipeline. My question to you was, again, continuing with what Shubhankar has asked regarding the high suicide rates. So as a routine, would you have a psychiatric analysis of patients considering the clinical activity score? Or, what is your practice?
Yeah, I think we don't have routine psychology involvement in our thyroid eye clinic. It'd be really nice to have that, but I don't think anyone will pay for it in our healthcare system. We do get distressed people, and I think we just take time with these patients, and we acknowledge that it's a horrible disease to have. We understand that they have low self-esteem and they don't want to go out, and they wear dark, sunglasses all the time. it's probably easier for them to do that in India than it is in the UK, because people walking around in the winter in the UK with sunglasses look very strange because it's dark most of the time. But this is what these people often do. So we just spend time with them. We acknowledge that it is a problem. We try to be reassuring and say, when your eye disease burns out, the NHS will offer you cosmetic surgery to realign your eyelids, or even do decompression to reverse the proptosis once the disease is burnt out. But some people are very frustrated by the fact they have to wait till their eye disease is burnt out to access those treatments. But of course, it's not a practical thing to do this kind of surgery in patients with active disease. You really have to wait till it's burnt out, otherwise it moves once you've done the operation. And so they end up needing a second or third set of surgery to rectify things. So yeah, we just acknowledge it. We talk to them about it. But it does have a, even in men, I saw a patient two weeks ago. This guy worked in a school and he didn't want to go into the school because the kids were staring at him, and he was staying at home and not going to work. So he lost his job. A guy my age, which, most people would be relatively, most guys my age don't particularly care about their appearance.
What is the youngest age at which you sent a patient for ablation, radioactive iodine ablation? And what is the longest follow-up that you have with patients who have been ablated?
Yeah, so that's a nice question, actually. And this is an area where we're quite proactive in this area. So we would certainly have no problem sending a child 16 or over it for radioiodine. And in selected cases, we'll do anyone who's basically post-pubertal. So if they've been through puberty and it looks like the best treatment for them, we'll do that. We tend to avoid it in these children if they've got a huge goiter, because they may need a second or a third dose, and that doesn't seem like a practical treatment. But if they in some ways those children, it's better to just send for surgery. But if they're very against having a scar and so forth, then then we will offer them radioiodine down to the age of puberty, occasionally below, but that's, we take this as a serious question, and we'll have the medical physicists talk to them as well about the treatments.
Thank you. And the longest duration of follow-up?
For radioiodine in kids?
Yes.
Well, we actually, once the kids are euthyroid and on levothyroxine, we tend to discharge them back to the GP, primary care. So we tend not to see them after a year or two in that situation. But we've had no problems with second malignancies or anything like that. But of course, it's Graves' disease in teenagers is like 4 or 5% of all Graves' disease. Is actually quite rare. So even though we see a lot of patients, our whole experience isn't huge.
Thank you. Thank you so much.
So I think we had a wonderful talk, wonderful evening, learning about new treatment options. Right now, possibly even Simon would agree that we are still stuck with the antithyroid drugs and radioactive iodine and surgery, possibly for the next 5 years at least, probably even 10 years, before these treatments actually become available in the clinics. But it's wonderful to know that we have other options coming up as well. So I'll thank profusely Simon for spending his time with us and all our audience, and of course ITS, Indian Thyroid Society, for providing this platform. And it's back to the organizers. Thank you very much. Have a very good evening.
Thank you.
Thank you, Professor Simon, for a very lucid presentation, and thank you, Professor Subankar sir, for chairing the session. So since we are nearing the end of the session, I request Dr. Arun S. Menon, Secretary of Indian Thyroid Society, to deliver the concluding remarks.
Thank you, Dr. Ganvi. on behalf of ITS, it's my proud privilege to thank all the faculty this evening, both the chairpersons as well as the speakers, and especially the international speakers who have stayed with us the last 2 hours or so. Dr. Matiullah Khan, Dr. Dina, Dr. Zenai, and Professor Simon Pierce. Thank you so much for making this a wonderful experience. Our national faculty have always been very supportive of our efforts, and we have seen that over the last 2 months of continuous meetings that we have had and the excellent academic sessions we have had. So without naming all our national faculty this evening, thank you so much once again to all of you. The academics has been one of the main areas that we have focused on, but however, there are many other areas that we would like to make a difference in, starting from patient advocacy, disseminating the right information to our patients, supporting research in the field of thyroid disorders. So we would request you all to join hands with ITS and make a real difference to the life of our patients. Before I conclude, I would like to thank the IT team, which includes Mansi, Asmita, and Bhavesh, who have been very supportive, and most of all, Dr. Ganvi, who has done an excellent job of comparing this evening session. So thank you all once again, and have a happy World Thyroid Day. Thank you.
Yeah, Arun, the next program.
Yes, so the next program will be next week, next Wednesday. So from June, we will be moving on to once in 2 weeks. So that the 1st of June, Wednesday evening would be our next program, which would be followed by June 15th. We'll of course send you the programs after that. But you can see the program displayed there. So we've got a wonderful session again in store for us. None other than Dr. Pramila Kalra, who is our scientific coordinator, who has done a great job over the last few months in getting us back into this academic, giving us such an academic environment. And Dr. Nitin Kapoor, who is, as you all know, an excellent speaker again from Vellore. So I'm really looking forward to this sessions next week. Good night, everyone.
Good night. Thank you. Thank you, everyone.
Thank you.
Thank you, Pramila, Ganvi, Arun. To all our esteemed faculty, Dr. Matiullah is still there.
Thank you, Madam.
Dr. Shubhankar, Dr. Simon Pierce, Dr. Nagesh, I think Shri Nagesh is still there. Minnie, thank you very much. Thank you to the digital team and MediSage as well for joining us. Ashmita has been there all along. Thank you. Thank you so much. Good night.
Good night. Thank you, everyone.
Thank you.